Good afternoon, everybody. This section is talking about the heart surgery, and I have Dr. Chen is the co-chairman for this section and will participating experts including Po-Sung Chen and Professor Chiao-Bo. And the first topic is infective endocarditis and current antibiotic strategy and post-valve surgery prophylaxis for invasive procedure. The speaker is the Dr. Ming-Cheng. He graduated from Yang Medical School and received his resident training in Merton General Hospital. Now he is the chief of the infection section at振兴 Hospital. Let us applause for the Chief Lee. Brief.
感谢座长的介绍。主办单位找我来讲这堂课的时候，他允许我用中文来陈述，所以抱歉的是，我今天真的要用中文来陈述。那中文呢，将是21世纪成为国际最佳之语言，希望大家呢能够接受，而且广泛使用。好，现在呢，我就开始我的这个 speak。今天谈的是 Infective Endocarditis 里面的，请看第一点，我们要讲的是它的致病的细菌种类以及抗生素的处理治疗之策略。第二点，我们讲的是开完刀后的 post-valve surgery， 它的有关于在要经由invasive procedure 处置的病人，他需不需要用 antibiotic 的一个 prophylaxis。首先呢，我们先简单介绍 IE。IE 呢是一个致病性的一种感染，它呢是我们心脏内膜的一种感染，而且最常发生在我们心脏的 cardiac valve involvement。那么总体来说，我们台湾呢每年10万人中有3至10人的发生率，那也就是说，大约一天中，整个台湾会有5个至6个的病人会发生 IE。可惜的是，我们张主任一直讲他怎么看到 IE 这么多，但是因为你身处振兴，振兴呢到处都是 IE， 所以我们碰到 IE 的机会比其他的医院来的太多啊。那再来的是哪一些是一个 IE 的 high risk patient 啊？第一个我们要介绍的是，当 patient 他有 prosthetic valve 的时候，这是 high risk IE。再来，他有 long term 的 intravascular catheter。比如说他装了 Porta A， 比如说他装了 PICA 等等这一类的病人，长期使用 IV 路径的人，他是一个 high risk。还有呢，像洗肾之病人，他也是个 high risk IE。再者有药瘾，经由静脉打药的人，他也是 high risk 的 IE。总共 IE 它是一个危险而 mortality 非常高的病人。mortality 大约在15到30%。那 IE 的菌种到底有哪一些呢？我想平常大家所经历到的，可能只会前面那一些，后面那一些大家大概很少看到啊。那么我们还是简单的来介绍，也不简单啦哈，因为我所有的菌种可能性都列出来。好，第一个当然好，我们呢目前最多的致病菌 是 Staphylococcus aureus。我在30年前的时候，我们 IE 的菌种第一名呢，应该是 Predictors， 60%-70% 的都是 Predictors。但是不晓得为什么，经过时代的演变，到今天我们 IE 最多的菌种却是 Staphylococcus aureus。那不管是 MSSA 或 MRSA， 那这些病人呢，他不管在 native valve 也是最多的，或者是在 prostate valve 也是最多的。那它呢，常常发生在 IV 的 addiction 的 drug addiction 的病人，也常常发生在洗肾，或者已经在我们医院常常看到的换了 valve 人工 valve 的病人，以及换了一些 cardiac 的病人。而且呢，它的临床表现是非常 acute 的，而且高病毒、高致毒性的。那么尤其在drug 的 abuser 的病人呢，他的 right side 的 IE 呢，常常是 Staphylococcus aureus 第一名啊。那么它呢会造成很大的毒性，所以它很容易 embolic 打出来，造成各地方的，比如说 CVA， 比如说 AMI 等。那而且呢，这种菌种呢，在 buff 里面不止 infection 产生 vegetation， 常常产生 abscess， 你用 anti 是打不完的，到最后都必须要开刀。所以我现在发现 MRSA 或 MSSA 的 Endocarditis， 我们 CVS 的 combined conference 都拿出来，后来都是开刀。好，那么 MRSA 呢正在增加，但是呢，他用的药呢 vancomycin 就是 Commando vancomycin， 它的 resistance 是越来越高。vancomycin 只要它的 MIC 大于1，就算是打了没效。虽然要2以上，它的 sensitivity 才会打 R， 但是你如果看到1以上的 MIC， 你就不要想你的 vancomycin 会有效，可以换其他的。Teicoplanin、Cubicin、Linezolid 好，刚才提到了这个 Predictors group 呢，是先前呢，在我30年前呢最高的这个 incidence 的菌种。那这些呢都是口腔的菌种，那包括最常见的是 Streptococcus mitis、Streptococcus sanguinis、Streptococcus aureus。那么这些人呢都有牙齿的疾病，或者经过牙科的处置，或他有 congenital heart disease， 那他常常得到的 IE 都是 Predictors， 他的 cause 比较 subacute 的，那么他呢常常是 penicillin sensitive， 但是呢有时候呢也会碰到所有的 beta-lactam 呢 resistant， 那就会改用其他的这个药物来治疗。好，第三个最重要，而且大家必须了解这一支菌的，看到这一支菌，你就要有很高的一个警觉，叫做 Streptococcus gallolyticus。那么以前呢，我们叫做 Streptococcus bovis。在这个我记得，在差不多20几年前，我在第一会试在讲这支菌的时候，下来后院长说叫我写这边全部的 paper， 他还说我们会派一个总医师来帮助你写，拍写后面没有写。好，那这个呢是在 native 的buff 呢比较会发生，在 prostate 呢比较少发生，而且呢这个呢都是在老年人发生较多。它之所以特殊是只要有 bacteremia Streptococcus gallolyticus 的病人，也就是 Placatio 产生这个致病菌出来，您就必须想到有 90% 以上是 IE， 这一点千万记住 90%。以后呢有人给你做 CPC 说这个人呢 Placatio 是长这支菌，你就不要管他了，你就往 IE 的方向走就对了。好，那它呢比较容易呢发生在老年人，而为什么特殊呢？除了这个以外呢，讲了 90% 以外呢，它就是很容易 IE combine colon 的 cancer、colon 的 adenoma 或者 colon 的 polyp， 还有2/3的 case 会发生。也就是有这一支菌的 IE 千万不要放过，测 CEA 测 CA199 以外还要做 colonoscope。 好，那另外呢有1/3的 case 呢会发生 liver cirrhosis 以及 hepatobiliary 的 disease。 好，那么它的 cause 呢比较 subacute， 刚才讲过它有 strong 的 association with coronary neoplasm 60% 以上。那大部分来讲它的 penicillin 是非常的 sensitive， 它的 MIC 大于都是小于 0.125。 好，那再者呢，那我们介绍就是 Endocarditis 的致病菌。那么 Endocarditis 呢，大部分呢是由 Endocarditis faecalis 所引起，飞菌比较少。那这支菌呢，不管是在 native 或者 prostate， 大概它的发生率是相当的。好，那也就是说，这支菌呢，在什么办法发生呢？在老年人的身上呢比较容易发生，在糖尿病病患比较容易发生，而且呢，这支发生的机会呢，都是在做过 urogenital 或者 GI procedure 的病人常常会发生 Enterococcus 的 IE。 好，那 general 来讲呢，它也是一个 subacute 的一个 cause。所以呢，它的 antibiotic 呢，在治疗上它比较困难，它需要 combined therapy， 也就是说，你最好选择2种药物，建议是首先选用 ampicillin 加 gentamicin。那因为它是普通来讲呢是 penicillin sensitive 的，但是如果万一非常不幸，你碰到现在院内的 VRE 的时候，你 vancomycin 都没有用。所以那时候呢，就要用高剂量的，所谓高剂量是每公斤每天10 ml， 每公斤10 ml， 大概在每天打500 ml 到800 ml 的 daptomycin， 我们商品名叫 cubicin。 好，那如果还不行，就最后一线的 linezolid。 好，下一张。那下面这些呢，就大家会比较陌生而不常见的，但是讲的第一支呢，当然还是很常见，就是 coagulase-selective 的 Staphylococcus， 我们一般就是控死。这个控死呢，最常见的当然就是 epidermidis， 那它呢很少发生在 native， 大部分发生在 prostate valve。 也就是说，当各位开完 valve 的刀以后呢，在early stage 发生 IE 的话，大家首选想到 Cons Staphylococcus epidermidis。 但是问题就是说，这个 early stage 跟 later stage 的定义有时间不同而不同，个人的想法不同而不同。但是我们美国心脏学会跟欧洲心脏学会一致认为，现在呢要以1年为界限，开完刀1年内的为 early， 开到1年后的为 late。 但是在我30年前，我都常常讲30年前，在我30年前的分界是2个月内的为 early， 2个月后的为 late。 所以大家各自想各自的看怎么治疗，凭经验啊。那这个呢，大部分是刚才讲，大部分发生在 prostate valve 或者是 CIED 的 infection。 那它常常呢，这个有跟 prostate valve 影响连接存在着，而且它的 MRSE 的机会是非常常见的，所以我们常常必须要用 vancomycin。 好，那再来呢，这个是大家比较少见的，也就是我们 IE 的常见菌种大部分都是 Gram-positive cocci， 但是有少数的大约2到3% 的病人的 IE 的菌种是 Gram-negative。 那在 Gram-negative 呢，我们就把它分成叫做 HESEC group 5种菌。 HESEC group 这5种菌呢，都是在口腔的 normal flora， 同样的跟 Predictors 是一样道理。好，那这5种菌呢，它呢都是由字头所连起来的。第一个 Haemophilus， 第二个 Colidia Bacterium Echinella。 那 那这个呢，大部分发生在 native， 而少部分非常少部分的发生在 prostate。所以大家呢，因为都是心脏外科的比较多，开完刀很少碰到这个，因为你都是 prostate buff 不会长这个啊。好，那这个之所以少呢，我可以呢告诉我自己的经验，我从40年来碰到 IE 治疗过了，亲自治疗过的病人，碰到 IE 的这个 group 呢，只有一个 case。我40年只有一个 case。我碰到的是第一个 hemophilus， 在 hemophilus 的所有的菌种都会发生 IE， except 除了一种，记得你不要去跟人讲 hemophilus influenza 会引起 IE 哦，这会被笑话，不会，好吧？或者选择题里面 except 什么你就选这个 hemophilus influenza 不会引起 IE， 最常见的是 hemophilus parainfluenza 这一支是 HESEC 里面最常见的。好，那它呢是发生在比较年轻的，而且都是经由口腔牙齿的治疗过后所发生。那么它在培养皿里面生长比较缓慢，大约要5-6天的时间啊。那它呢比较 sensitive 的第3代的 cephalosporin， 所以在治疗上不要迟疑，就用 ceftriaxone 就好了。好，再来就是 coagulative 的 IE。coagulative IE 呢，你也不晓得它是 IE， 因为你培养不出来，你就不会诊断为 IE， 常常是这样子。但是如果你是有 IE 的表现，或者是 echo 你真的看到 IE， 你真的要觉得它有可能是 coagulative 的一个 IE 啊。好，那 coagulative 的 IE 呢，有什么会造成这样的情形呢？第一个，他呢先前用过抗生素的病人，或者是有一些很难缠的、很难培养、很难养的细菌，它会产生 negative 的 IE。好，那这些包括哪一些呢？比如 Coxiella burnetii。那什么是 Coxiella burnetii 呢？大家不好记，不过你只要记得立刻刺题的 Q fever 就是。好，再来 Bartonella， 那 Bartonella 好不好记？不好记。好，那不好记呢，记什么呢？你记猫抓病的啊，就是这种菌，或者记得战壕 fever 啊 ，trench fever 就是这个。好，再来 Brucella 啊 ，Brucella 布鲁氏病啊，或者是下面这个 Trifoma 那个也很少，是里面最少的。那你要记它，就把它跟放射菌 Actinomycosis 记在一起，它是类似的就好了啊。所以呢，它常常呢说是这个在诊断上，它因为没有办法catch比较困难。那它就是说，你高度怀疑它有很明确的一个 exposure 的 history， 你就要怀疑是这一些。那这一些呢的诊断都是靠 serology 啦、PCR 啦、molecular 啦这些来诊断啊。那些呢，这个治疗呢就被个别的有它的治疗，但是大部分都可以用这个举例，像 Coxiella 呢就用 doxycycline 加上 rifampin。好，那最后一个还有呢就是 Pham 的一个 IE， 我们医院外科也常常碰到 Pham IE。 那这 Pham IE 呢，大部分呢在是 immune 的一个 compromise 的病人，或者是在 IV drug 的 addiction 的病人，或者心脏开刀以后长期呢会用在 catheter 的病人。那它最常见的是 Candida 跟 Aspergillus。 好，那这个呢它是非常少见的，但是它是 high mortality。 好，常常都是治疗稳定之后一定要开刀，逃不了 fungus 的 IE 要开刀，因为 fungus 的 IE 它的 vegetation 都很大，甚至于要大到2公分以上啊，所以呢它呢万一打出来的话都切掉了，所以呢大部分都是要外科的治疗才有办法。好，那它呢在这个anti-fungal 方面呢是用 caspofungin、bicafungin 或者是 emtricitabine B。 那这个呢，刚才那2张slide呢的指引呢，是由美国心脏学会医学会跟那个欧洲的心脏学会所用出来建立出来的 guideline 指南。那这张呢是另外在 JAMA 上面的一个 guideline 我稍微再讲一下Streptococcus 那 Streptococcus 呢，它的治疗呢，大部分呢以 penicillin G、ampicillin 或者 ceftriaxone。那如果呢碰到比较没有 penicillin sensitive 呢，就用 vancomycin。那如果 MIC 比较高的，我们加上 gentamicin。要是有 allergy 的话呢，要用 vancomycin 或者是 linezolid。那 MSA 或 MRSA 呢，在 MSA 呢，我们用 oxacillin 2 gram Q4 或 ceftriaxone 2 gram Q8。那如果它呢有比较这个prostate 的 buff 的时候，它呢需要用加上氯芬吡300 Q12 或300 Q8。它如果有 penicillin 或者 beta-lactam allergy， 就使用 vancomycin、daptomycin、linezolid。那 MRSA 呢，那当然一定要用 vancomycin 1 gram Q12。那如果其他的就可以选用比较高剂量的 daptomycin， 一般使用的是每一天每公斤10个 ml， 大概每天打500到800之间。要是在 prostate buff 的，因为 prostate buff 会产生生物膜，所以呢我们就要加上氯芬吡300 Q8 或300 Q12， 在其他的替代药物就是 linezolid。那在 Endocarditis 呢就用 ampicillin 或者 vancomycin。那如果有其他的比较难产的，我们当然会加上 gentamicin， 因为刚才讲过 Endocarditis 是需要复方治疗，所以用 ampicillin 加 gentamicin 或 vancomycin 加上 gentamicin。那 Hesic 呢，刚才讲过，它是 cephalosporin 第3代、第4代、第5代都会有效，所以我们都用取第3代的 ceftriaxone 2 gram QD。好，那如果 beta-lactam allergy 的病人，我们可以改用 quinolone 的 levofloxacin 及 prophylaxis 取代。那其他的 gram-negative 的 bacteria， 除了 Hesic 之外，当然都要跟 infection 来讨论会比较好。但是如果是这一些，当然它已经被 capture 出来，一般呢第3代、第4代、第5代的大部分会有效的，我们选择有效治疗。而且如果是 allergy 的时候呢，就选择 levofloxacin、prophylaxis、moxifloxacin 来取代治疗。好，那接下来呢，讲第2个 topic 呢是 hospital valve surgery 的 prophylaxis antibiotic for invasive 的 procedure， 也就是说如何要避免 IE 的产生。我们总结呢，要避免 IE 的产生呢，就是在 high risk 的 patient 加上在处置 high risk 的时候的 procedure 的时候，这2者相加一起，就才需要 antibiotic 的 prophylaxis， 而不是一般的心脏病患在处置牙科的处置就需要，这样子会避免了这个抗生素之滥用。那哪一些是 high risk 的 IE 病人吗？这里就有以前得过 IE 的，曾经手术过换 prosthetic valve 的如果有 cyanotic congenital heart disease 的，或者是你做了 heart disease 的这个治疗手术在6个月以内，因为内皮还没有完全成熟，这些病人是 high risk。那还有我们常在医院发生的 heart transplantation 的病人，他如果说把产生 pathology 病变的时候，他还是属于 IE 的 high risk patient， 加上下面这些高危险之处置的病患才需要 antibiotic 的 prophylaxis。 哪一些属于 high risk 的 procedure？ 只是在 invasive 的 dental 的 procedure， 包括紧夹吧，包括 pediodontology， 包括 extraction， 尤其是拔牙最常见。 那如果是在呼吸道的手术呢，做 bronchoscope 是不需要抗生素预防，但是如果 bronchoscope 再加上 biopsy 就需要 antibiotic 了。好，那另外呢，在做 tonsillectomy 的时候需要 antibiotic 的 prophylaxis。好，那如果在cellulitis 等等的皮肤骨骼肌肉需要 drainage 需要手术的时候，他应该会先治疗他的这个感染。他如果有在治疗，他就等于在 prophylaxis 这个 high risk， 那就不怕。他如果还没有开始治疗，你要做incision drainage 等等，就需要 antibiotic。好，那这些呢表呢是主要是讲出刚才呢哪一些是 high risk 的 IE 的病人，那这一些都是我刚才已经讲过了啊。那这只是拿出来说是另外的journal 里面的 comment。好，那有关于这个 moderator 呢，就是不需要 antibiotic 的 prophylaxis， 但是在30年前，这一些都是被列为是的，像 rheumatic heart disease。30年前是需要 antibiotic prophylaxis， 但是现在不需要，不被心脏那个美国心脏学会以及欧洲心脏学会他们的这个 comment。 好，那其他的像 mitral valve 啦 prophylaxis 啦这种 MVP 以前也是需要，那现在的建议是不必。好，那这张呢是列出来哪一些危险的 procedure 需要antibiotic prophylaxis， 主要呢我们是要看上面比较 invasive 的这个 procedure 的，大部分呢都是在牙科的，像牙科的这个拔牙啦，牙科的这个 oral surgery 啦，或者是根管治疗啦，那这一些有黏膜出血会产生口腔内 bacteremia 的 case， 有 high risk 的 IE 的 patient就需要 antibiotic 的 treatment 的 prophylaxis， 如果没有那就不需要。像下面这些都像下面刚才讲，像下面这些都不需要。好，那这个呢图表呢是表示说你在 high risk 的病人，那么做了 invasive 的 dental procedure， 你的 IE 的确是拉高了。好，那这两个呢，一个是做拔牙，它的确在 high risk 的病人是拉高了。好，那这一张是做 surgical 的 oral 的 procedure， 它呢 high risk 的病人呢，它 IE 的 case 也拉高了。好，那这张是讲说什么情况下 antibiotic 的 prophylaxis 到底有效没效来看。好，第一个，你这个 high risk 的 patient 在做 invasive 的 dental procedure， 你如果有做抗生素的预防，那你的是平安无事的。如果你没有 antibiotic prophylaxis， 它是 IE 拉高的。那这个呢都不需要做，因为它呢都是不是很重大的一个risk high risk 的。但是呢这一个 high risk 的 patient 再加上拔牙呢，就很明显，它没有 antibiotic 的 prophylaxis 的时候，它是拉高的。IE 是拉高的。好，那这个呢是 high risk 的病人，他经过 oral 的 surgery 的时候，你如果没有 antibiotic prophylaxis， 那他的 IE 病人同样是拉高的。所以呢，这个呢是代表着说 high risk 病人再加上 high risk 的 procedure， 他需要 prophylaxis， 因为他们的 IE 相关联性太高了。而且只要你有 antibiotic 的 prophylaxis， 它证实它有重大的降低 IE 的 incidence。那这个呢，就是说在所有的 high risk 的病人来做什么 procedure 需要有这个 prophylaxis。像这个这么高的一个 IE 的 incidence， 它就是因为拔牙，所以这拔牙在 high risk 需要 AP 的。那像 bronchoscope 是不用的，但是加上 biopsy 就需要。在 colonoscope 大肠镜方面，他们看起来有一点高，但是它是不需要的，不建议 antibiotic prophylaxis。但是如果做 colonoscope 再加上 biopsy 就需要 antibiotic 啊，那这个中等的或者是低的这个 risk 的病人，都是做什么都是很低的 IE risk， 所以不需要抗生素的预防。那这个抗生素的预防的这个种类呢，大部分呢，第一个如果是呢这个做 dental 的，那防 vigilance 的，就用 amoxicillin， 在手术处置前30分钟到60分钟，用2 gram 的 amoxicillin 口服单剂量即可。如果 allergy 的时候，用 Clinda 单剂量600，或者 azithromycin 单剂量500即可。如果是呼吸道的，我们要预防 Streptococcus、Staphylococcus， 那同样的 prophylaxis 呢，在做30分钟、60分之前呢，口服 amoxicillin 2 gram。如果 allergy 就用 Clinda 600 mg 口服。如果你做了 GI、GU 这种可能有 infection 的 procedure 的时候呢，它要防止的是 Endocarditis， 那它的口服的，它用那个 ampicillin 或者 amoxicillin， 这时候呢，它是用 IV 的 prophylaxis 2 gram stead 单一剂量啊。那如果呢 allergy 就用 Benco 1 gram IV 单一剂量啊。那如果你是 skin 或什么皮肤上的骨骼的这个procedure 呢，你所预防的是 Streptococcus 或 Staphylococcus aureus， 那么你预防的用药呢，就是在做 procedure 之前呢，30分钟到60分钟呢，用 IV 的 cefazolin 1 gram one dose 即可。如果你 allergy 用 Clinda 600 one dose 即可。如果你是做心脏的procedure， 比如说你放 Davis， 那 Davis 有关的是 Staphylococcus aureus 或者是 Crohn's， 你用 cefazolin 1到2 gram IV， 或者是你 allergy 的时候用 Vancomycin 的1 gram stead 因为时间关系，所以我要结束，拍摄
Okay, next we will move to next topic. We invited Professor Jennifer Chang from Toronto General Hospital. She's a cardiovascular surgeon and the director of thoracic aortic surgery clinics. And I think she already mailed the video, so let's play the video.
Hello, I'm Jennifer Chung, and I am a cardiac surgeon at Toronto General Hospital. And I'd like to thank the organizers for inviting me to speak with you today. And the topic of my talk is the UFO or Commando procedure for severe infective endocarditis. So this procedure was pioneered by Dr. David, and he published his original series back in 1997. And his early experience included 43 cases, and they were for a number of indications, including endocarditis, degenerative calcification, and small aortic and mitral annuluses. There are several variations for this procedure. They all involve an incision across the intervalvular fibrous body, cutting open the dome of the left atrium to provide exposure to the mitral valve from above. The simplest variation is to replace both the aortic and mitral valve with a double patch closure, one for the dome of the left atrium and another patch to close the aorta. The next variation is just below, where there's MAC or some need to reconstruct the posterior mitral annulus, in which case a pericardial patch is used to patch that defect close after debridement, and then you proceed with the double valve, double patch technique as described. This is, of course, a precarious undertaking whenever you have to do MAC debridement, especially in these UFO cases. And so a variation that Dr. David has described is to use a Dacron tube. And you can sew it into the ventricle and left atrium. And then within this Dacron tube, you place the mitral prosthesis, and this tube essentially is a funnel for the blood flow from the atrium to the ventricle. Then, of course, you can replace the aortic valve as part of a full root replacement or Bentall procedure. So this is a case that I did last month, and unfortunately I received this invitation to talk after the procedure, and so I didn't record it, but I hope to share the details with you nevertheless. So this was a 43-year-old male presenting with prostatic valve endocarditis. His past medical history includes a mechanical Bentall done in 2014 by one of my partners, and this was complicated by the need for a pacemaker. He suffered an NSTEMI in 2019, secondary to warfarin non-compliance, and he had an embolic MI. And then he also is known for substance use disorder, but this was quite stable on methadone at the time of his presentation. He is also obese with obstructive sleep apnea. So he presented with progressive decline in function over several weeks and was admitted with sepsis and heart failure to an outside hospital. They diagnosed endocarditis. The blood cultures grew Enterococcus faecalis, and the echo confirmed both aortic and mitral valve endocarditis, an aortic root abscess, and possible lead infection, and he was transferred to our center. So here you can see the echo images. And the top left, you see the very clear mitral valve vegetation, and then on the top right, first you can see the mechanical Bentall, but more dramatically you do see this severe MR and mitral valve perforation. On the bottom left, you see a very obvious and clear and quite extreme case of aortic root abscess. And then on the bottom right, you can appreciate this fistula into the right-sided chambers and severe TR. So step one is the setup of the case. Clearly he needed a reduced sternotomy. That part was completely uneventful. For cannulation, I selected axillary artery, partially for the redo, but also because the aorta was replaced fully, I wasn't sure if a hemiarch was going to be required. Thankfully not. I was able to dissect it out a lot where I could clamp native aorta, and then for venous drainage, SVC, IVC. For such anticipated long cases, I think myocardial protection is key. You can do a lot if you can protect the heart well, and so I like to cool down to 30 degrees Celsius nadir temperature. For cardioplegia, Del Nido was used. I think, again, because myocardial protection is key, and we won't have ready access to the coronary ostia, and there is AI, and so I planned for retrograde cardioplegia. The right atrium is open anyway. We want sure, ready, secure retrograde cardioplegia flow, and we want to ensure that it's also not placed too deep, so direct vision snaring of the cannula at the orifice of the coronary sinus is the key. But I never feel comfortable in such long cases to give retrograde alone, and so there was plenty of intermittent direct coronary ostial cardioplegia given during this case as well. So with the right atrium open, we can pull out the pacer wire leads and cut them as proximally as possible. So step 2 is debridement. So when we open up the aorta, we are working inside an old aortic graft, and we know that this can be quite a tunnel. Splay it right open, and then the first step is just to make the coronary buttons, open up the visualization of the aortic root. Then we remove the previous aortic valve completely with all the pledged material, and I have the preoperative CT scan here just to show what we are anticipating to see and what we did see, which are all those pus pockets that were identified. And so all of that needs to be fully debrided, suctioned away cleanly, and that's what we did. Upon entry into the left ventricle, we also encountered quite a heavy burden of vegetations, which we carefully removed. There was a large defect in the anterior mitral valve leaflet. This was not a case that would be appropriate for a hemi-commando. That entire anterior mitral valve leaflet was gone and obviously non-salvageable, so that was excised and removed. In the process, we of course opened up the dome of the left atrium, and that is what is, I suppose, a little bit special about this UFO procedure is this exposure to the mitral valve. You can see that on the right-hand side picture. And I think the only thing I would edit to that picture is that we can't appreciate the three-dimensional qualities very well in that figure. And the dome of the left atrium is a lot more three-dimensional, and it definitely dives deeper down. So that's that. And then luckily in this case, the posterior mitral valve leaflet was entirely normal and could be left. And that also means that those cords could be salvaged. Next, we examined the fistula to the right atrium and right ventricle. It's very important to examine that from the right side. And indeed, we encountered vegetations on the right side, which were then debrided. In the process, we did detach partially the tricuspid valve in that area. So with everything fully debrided, then we do the general good practice items for endocarditis. That includes sending all the samples to microbiome that we want to. Everything is suctioned and irrigated fully. And then all instruments that were in the field, suction tips and gloves were changed. Now we enter the reconstruction phase. So I started with closing the ASD-VSD, and that was just a linear closure with mattress sutures, and then we attached the tricuspid valve. Then through the dome of the left atrium, we can insert our mechanical mitral valve. So when it comes to sizing, we want to size it to sit nicely such that the native annulus circumference covers 2/3 of the valve, and not to get too greedy with the size. So here we selected a 31 millimeter St. Jude. Next, we close the dome of the left atrium with a Dacron patch, and we can talk about patch selection in a little bit. Now we're left with a defect in the aortic side. So as you recall, there's a bunch of abscesses that were cleaned out. So the circle that we're following is obviously inside the LVOT, as there is no annulus left at this point. And then that circle continues on to the anterior aspect of that mitral prosthesis. So here what is needed is a LVOT Bentall. So we performed a end-to-end anastomosis of a 30 millimeter Dacron graft to this circle that I described. Next is to sew the aortic prosthesis inside. And it's always 5 less than the Dacron graft that you chose. So here, a 25 millimeter St. Jude is chosen. The key here is to remember that we have to sew the buttons back on. So while we would like to have a nice curtain between the aortic and mitral valve, but we also have to be very realistic about how much these buttons can move in a reduced setting. And what will kill this patient will be button complications. And so fully mobilize the buttons as much as you can, and then see where they are positioned on the graft. You can mark them with a marker on the graft and position your valve accordingly, and even anchor them in a couple of locations with Proline. Contrary to the figure on the right, I don't use mattress sutures for this. I just run it with a 3/0 Proline. Sometimes cabrals are needed for redo Bentals, as you know, but thankfully in this case that was not needed. So step 4 is to complete the case. The tricuspid annuloplasty was performed, and then close the atrium. When it comes to separating from bypass, the first time is always the best time, and so we are anticipating issues. Of course, this was a long case. Patient presented with heart failure, so we started at nitric oxide right away. Both pleural effusions were drained, and inotropes were started, and we were actually able to separate from bypass very smoothly on the first shot without issue. The next phase is far more challenging, which is hemostasis. Clearly, all surgical bleeders that are obvious should be taken care of already by now, but still likely you will see lots of bleeding, and that's what we had in our case. One tip that multiple surgeons have told me over the years, and it seems to be true, is that for cases like this, if you are able to keep up with the bleeding with a single pump sucker, you may get away with it. And indeed, when we were in that situation, we had to bite the bullet, administer protamine, and then just pack. With administration of blood products, we were actually able to close. And so thankfully he did dry up, and we were able to achieve hemostasis. It tends to sort of happen, it seems suddenly, the transition from bleeding a lot to good hemostasis. Then the previous pacemaker was removed, as well as the residual leads in the innominate vein. These patients we should anticipate problems for and set them up for success in the CVICU. And so we floated a swan at the end of the case to help direct care in the ICU. And because the urine output dwindled towards the end of the case, we inserted a VAS cath right away prior to leaving the operating room. This is his post-pump echo. You can see both valves working well, and that's it. In terms of the post-operative course, he had, thankfully, quite a smooth post-op course. He did require SLED for about 48 hours, but his urine output picked up, and his creatinine normalized by the time of discharge. We inserted a new PPM on the right side, and of course a PICC line was inserted. All the OR cultures, as expected, were positive, but what's more important is that all of his post-operative blood cultures were negative, and then he was discharged to his home in 14 days. This is his post-operative CT scan. You can see that pacemaker now on the right side. You can see his new aortic graft. All that old aortic graft was fully replaced, and you can appreciate that on the sagittal as well. You can appreciate the relationship between the aortic and mitral valves. And I think the this sagittal view demonstrates that dome of the left atrium, what I was talking about, how it really dives down, perhaps more than you may think. And then the tricuspid annuloplasty too. So what are outcomes from the UFO/Commando operation? So Dr. David updated his personal series a few years ago with 182 patients, and the average age was 62 years old. This is a very sick cohort with 60% of patients in a NYHA4. 40% of patients had a previous sternotomy, just like the patient we reviewed, and many more had multiple sternotomies. Minority of the cases were for endocarditis, only 13%. You can see that his operative mortality was 13%. 100% of these patients require blood transfusions, and oftentimes it's a lot. And they have multiple types of complication post-op, including renal failure. pacemaker implantation, and atrial fibrillation. In terms of long-term outcomes, they are not definitely not the same as the general population. So by 10 years, half of these patients will have died, and they are often valve-related or cardiac-related events. These were what Dr. David found to be predictors of outcomes in that paper. Number one, reconstruction with Dacron graft is protective. And so he has found in long-term follow-up that bovine pericardial patches can crack and be associated with complications. And so he advocates for the use of Dacron graft in younger patients, and that's what we did here. Calcification of the mitral annulus is obviously bad. MAC cases are more dangerous, and so this is an understandable predictor of outcome, as is NYHA4 classification. In terms of long-term reintervention, you can see that there is a steady rate. The early hazard comes from early prostatic valve endocarditis. These are nasty endocarditis cases, heavy burdens of vegetation and abscesses, and so we can understand why some of these patients may have come back. In terms of late reoperations, we've already discussed patch fractures and dehiscence, and there have also been cases of mechanical valve thrombosis. Of patients who needed reoperations, 4 out of 14 died. So this is a high-risk undertaking. And only a few of the patients were candidates for transcatheter reintervention. So most reinterventions tended to be open surgery. So to summarize, this is, of course, a very useful technique for combined aortic valve and mitral cases with involvement of the intervalvular fibrous body, and this includes cases of endocarditis. These are very long cases, but with good myocardial protection, thorough debridement, and meticulous reconstruction, good results are achievable. And in Dr. David's series, with a 13% operative mortality, and that's very favorable in the literature. And as you can see from the data, these patients need to be followed as long-term complications may occur. Thank you very much for your attention.
All right, let we move to next topic. We invite Dr. Chen Po-Sung to share the topic on modified Commando operation,振興General Hospital experience.
Okay, greetings. I'm Dr. Chen. Today I will present a case of modified Commando operation in振興General Hospital. As we can see, the Commando procedure is mainly to treat with the outer mitral curtain, also called IFB. The tissue here is very, very, very thin, and we need to treat this anatomy very preciously. The conventional approach was told in previous topic. Now we will show the difficulties. The major difficulty is relative complex procedure. So the exposure and the annulus interposition is very, very difficult. The annulus interposition also causes the difficulties in hemostasis and after procedure paravalvular leakage risk. So in our series, we applied the superior septal incision in addition to the LA dome incision to get a better exposure. Besides, we used folded page. Let me show the step by step. We use a whole bovine patch and split to 2 patches and to fold it to create a new IFB as the suture line. Then we can see the folded patch will divide it into 4 parts. There's 2 smaller parts were used to reconstruction aortic annulus and mitral annulus. Besides these 2 parts of longer patch is used to reconstruction of our aorta and LA dome. This is a icon. We can see that this is aortic valve and mitral valve, and the new IFB suture line will put in here to create a new IFB. And these two smaller patch will one for aortic annulus and one for mitral anterior annulus. These two smaller patch will release the major tension of the intervalvular interposition, and beside these two patch can sealing and make a better hemostasis and prevent paravalvular leakage after procedure. This is another picture for the valve space. Yeah, we can see again aortic valve and mitral valve here. The outcome in general in Jianxing General Hospital, we have total 29 cases from 2016 to 2055, and we can see there's mostly redo cases and a relatively lower mortality case. The total number is 29, and these 29 procedures performed in 26 patients. The mean age is 57 years old, and the male portion is 65.4%. The indication was major is infective endocarditis, including 26 patients, and 86%. And the major and main part of this patient was prosthetic IE, including 20 patients, and near 70%. Besides, we have three severe IFB calcification or mitral with aortic valve annulus calcification. And one case is anatomy unsuitable for simple double valve replacement, including a LVOT stricture and a small aortic valve annulus and a small mitral annulus. So we conduct modified Commando procedure for this case. Besides, we had three Commando redo Commando cases, and the concomitant procedure in our series is 24, and is more than 80% in our series is need more than the Commando procedure, so it's a very, very complex series. And the major concomitant procedure many were paravalvular reconstruction, including aortic annulus reconstruction, mitral posterior annulus reconstruction, or VSD closure. The total in-hospital mortality were 3 cases. There's 2 cases in our hospital who the first is died due to the persisted sepsis and unfortunately mortality. And the next case is the case underwent the 3 cardiopulmonary bypass during the operation due to the mechanical valvular dysfunction. And she received the ECMO after operation and presented with heart failure and persisted sepsis. The third case is a pre-operation liver failure case due to the valvular disease. And after operation, the heart function improved. However, liver failure persisted. So the patient sent to other hospital for liver transplantation, and the follow-up showed the patient finally died. The Commando redo Commando 3 case pathogen, including 2 Staphylococcus epidermidis and 1 Staphylococcus haemolyticus, This pathogen is different from the early serious finding. We found the early serious finding the pathogen is mainly Staphylococcus aureus, but currently we found the Staphylococcus epidermidis and the become more popular, and it's very difficult to treat and to eradicate this pathogen. The total hospitalization in our series is very in each patient is relatively longer because the antibiotic treatment and in the Taiwan HI policy, so the hospitalization is mainly in near 19% more than 30 days. Besides, it's very important that the notory tract bleeding rate in our series is 0. It's very good result for this modified Commando procedure. Let me show some picture. This is a vegetation of aortic and mitral valve and to the LVLT's aortic mitral curtain abscess. Besides, aortic valve caused over LCC with a perforation. We can see a perforation here. And the mitral valve we can see there's multiple vegetation over anterior mitral valve leaflet and multiple perforation at the IFB tissue. This is a removed mitral valve ring. This is a posterior mitral valve annulus, and the annulus here is relatively intact in this case. So we perform a mitral valve replacement and a new IFB reconstruction as previous told method. Then reconstruct with an MVR and AVR. Then reconstruction the LA, Dong, and the aorta. The next case is a posterior mitral annulus reconstruction. The finding just similar to previous case, and but we can see there's a very, very destructive mitral posterior annulus. So we reconstruct the annulus with bovine patch as this compression method with filter suture. This is a contracted mitral annulus. So, in summary, modified Commando operation in Jiangxin General Hospital, we conduct this operation as an indication for treating severe IE patients. In major is aortic or mitral valve paravalvular abscess, including IFB perforation or IFB severe calcification. Beside the severe NAC with IFB calcification or the anatomy called unsuitable for single valve replacement, we also perform a Commando operation. The advantage of our modified method who can lead to a better exposure and better hemostasis. So, in summary, this is maybe a repeatable procedure. Thank you.
Professor Xu, do you have any comment?
Thank you for your presentation and show the excellent result of your hospital. I have a question about the when do you select the Commando procedure and the double valve replacement and with the debridement of the fibrous body with or without the patch repair?
Because the incision line, we can adjust and to adapt the DVR to Commando procedure. So we perform autotomy first and the bilateral approach first. Then if the abscess or the IFV perforation is relatively severe, we conduct the Commando procedure. The major indication or the major choice to the Commando procedure is the severity of the destructive tissue or the suture stability.
Integrity of the automitral curtain. If the integrity of the automitral curtain is not secure to fall on, then we will do the Commando procedure in our hospital. Sometimes I just use the patch repair and straighten the security. So because we are not sure that the agreement is enough. If we leave the native tissue there, sometimes the infection will go on. So for security, we will take out all the automitral curtain, then use an artificial part to reconstruct the automitral curtain. I think the most important for treatment of the infected endocarditis is enough debridement. If you leave any infected tissue still there, then the infection will go on. Yeah.
How to make sure you have performed the adequate debrid?
Well, sometimes we add on to use the glutathione to sterilize the tissue, but I think, well, sometimes some surgeons think it's a poison, but I think so far we use the glutathione with the extensive debridement. I think the recurrence rate is very low. Yeah.
Okay, time is out, and we will close the section. Thank you.
Well, every year, Professor Wei asks our TAVR team to do something new and to improve our skill and outcomes. So we try to have some innovation and presentation in the international conference and the publications. So today we organized some of them. We thought it's interesting. So then we present this to you, and hopefully that you can give us some suggestion to make our refinement and improvement. The first topic will be TAVR for bicuspid aortic stenosis. As we know, bicuspid was used to be excluded from all the randomized control trial because it's anatomically it's difficult to implant a valve because the valve implanted should be circular in shape. However, the bicuspid you almost always avoid in shape, so parallax and elliptical configuration after implantation is the rule. This is because of the heavy calcification to some extent, and from the largest bit registry, it shows that if we use a balloon expandable valve, trying to make it circular, you may have a higher residual gradient because you intend to implant a smaller valve. And if you use a bigger valve with aggressive post-dilatation, then a higher rate of annular rupture will develop. If you play safe to choose a self-expanding valve, then you will end up with a higher rate of residual moderate to severe PVL because the radial force is not that much. So you have a small defect on both sides. So it will cause paravalvular leakage. All these things happened because there are asymmetrical calcification of the bicuspid aortic valve. Sometimes the calcification just happened on the leaflet. Sometimes it's in the commissure, and sometimes it's in the raphe. So it is well known that calcified raphe and excessive leaflet calcification were associated with increased risk of procedure complications and midterm mortality. I think the most important concepts come from Dr. Didier Chae, who present that we should consider the bicuspid aortic valve anatomy and the relationship with devices. The data was drawn from valvular registry. They measure annular diameter and the supraannular diameter, which was measured 4 millimeter above the annulus, the intercommissural distance. Then they compare the distance supraannulally with the annular diameter to categorize the aortic root anatomy into 3 categories. One is the tube shape. That means the diameter was equal on both sides. And the second one is the flare type. The intercommissural distance is longer than the aortic annular diameter. And the more risky is the taper type. Taper type means that the intercommissural distance was shorter than the annular diameter. That means the calcification of the bicuspid anatomy is almost always at the leaflet level instead of the annular level. This may result in different anchoring anatomy and position comparing to tricuspid leaflet. That means that if you implant the transcatheter heart valve, the anchoring zone will almost always supraannular instead of annular anchor. For this kind of taper shape, if you choose conventional annular sizing, then we'll end up to choose a larger THV, and that may cause some problem because at the supraannular level, it cannot be open in circular shape, and if you dilate aggressively, then you may result in leaflet injury or even aortic injury. So we have found this very early in 2016. After discuss with all the team members, we developed a so-called waste method. We measure the supraannular level to find the level with the narrowest leaflet opening during systole. That means this should be the anchoring zone or anchoring level of the transcatheter heart valve. Then we measure the intercommissural distance. To address the calcification, we also measure the short distance from the leading edge of the calcification to the aortic wall. Then we average these two numbers to get an averaged valve diameter at that level. Then we use a conventional annular sizing to get the annular diameter. Then we compare these two and choose the smaller one as our reference diameter for balloon sizing. In this way, we can get a minimum diameter for safe anchoring. That means in this diameter, you can anchor the valve without migration or dislodgement. And then you may still have some residual leak, but that can be solved by post-dilatation. That's the idea undermine this kind of measurement. So with this, we found that it can be applied in most of the bicuspid case. The only one exception is that if the bicuspid is a type 1 and the both leaflet have heavy calcification, then you might not be able to open up in between. So the short distance should be measured from the leading edge of this side and the other side. That means you may have to choose a smaller one, even smaller one. This is some example showing that how to measure by the waist method at the supraannular sizing. We did that routinely with the use of a balloon expandable valve initially, but later we want to make sure this concept can be applied to self-expanding valve too. So we analyzed our data from 2017 to 2021. We use Sapien as the default THV. However, to get experiences, we use Evolut R or Evolut Pro routinely for bicuspid cases from 2021 to 2022. We get 32 cases. If we use a balloon expandable valve, you know the beauty of the balloon expandable Sapien valve is that you can adjust the balloon volume to achieve an expected balloon diameter finally. And then you stabilize, develop the valve. We usually do pre-dilatation in bicuspid, initially for sizing purpose and also to see whether the calcification can be moved, and also the interrelationship between the calcification leaflet and the coronary. And then we position and anchor the valve according to the waist method. Then if there was still leak, we posterior for optimization. You can posterior the inflow or the outflow for better anchoring or leak sealing. This is an example. As I shown previously, this is a type 0 bicuspid with heavy calcification of under both leaflets. So we measure the short distance in between and the interconventional distance like this, and average them to get a 23. If you use conventional sizing, we can also get a 23.3. So it's a tube configuration. So it's easy to do that. Firstly, we use 23 Sapien 3 full volume to anchor the valve. Because there is still some leaks, so we add 1 cc and optimize by post-dilatation and get a satisfactory result. So that's what we did for balloon expandable valve. For self-expanding valve, we think we should avoid aggressive oversizing. We still use the cost overlap view for implantation and aim higher, because the true anchoring zone is supraannular. If we put it too deep, then the valve will constrain by the supraannular anatomy. Then it will compromise the hemodynamic performance, and we think that it will be worse, worsen the clinical outcome. If we want to open the valve to be circular, then you need also optimization by post-dilatation. We also do balloon sizing in these cases. The purpose is that first to sizing, second to see the anatomy changes, and 3 is to facilitate the crossing, valve crossing. In this way, we can do TAVR with self-expanding valve also. And as you can see, this valve can be implanted much higher than the tricuspid aortic stenosis. As you can see, it doesn't matter because at the annular level is ovoid in shape, but in the leaflet level or the anchoring level is a circular relatively and have a only minimal amount of leak. This is an example that by waist method, we get a 26.6. But if you use a conventional annular sizing, you will get a 29. Then we follow the rule to use a 26 valve, and the final result was good. This is another case. We measured supraannularly, it was 20. By annular sizing, it was 23. So we chose a 23. Based on this, we should choose a 23. So we also implant the valve higher than tricuspid implantation and post-dilatation. And as you can see, after aggressive post-dilatation, we can get a satisfactory result. So you may have appreciated that if the calcification or leaflet thickening is severe, then you will tend to end up with getting a taper or configuration. This is the third patient. We use a Weiss method and annular sizing, both yield 22. So this is a portical case. So we use a 25 portical. And after aggressive post-dilatation, initially the valve was underexpanded, and after aggressive post-dilatation, you can get a satisfactory result. So with our method, we can do TAVR with both balloon expandable valve and self-expanding valve with equal or comparable result. This is our data showing that bicommissure raphe was presented in more than half of the cases. And the asymmetrical distribution of calcification and calcified raphes is almost always there. So if you choose the valve based on Weiss method, you can get a very good outcome without any annular rupture. And the severe success rate can be achieved with the use of both balloon expandable or self-expanding valve. The device success rate was similar. And it is interesting that residual power leak was almost comparable between the two groups. And although the mean post gradient was significantly higher among those patients with BEV, about 11, but actually the estimated arterial area was similar in both groups. The implantation depth was significant deeper in the self-expanding valve. This is no wonder, because the valve design will make the implanter end up with this result. But actually, the permanent pacemaker rate was similar in both groups. So recently, Dr. An from Asa Medical Center wrote a paper review, which was under submission and review by international journals. They put our Weiss method in the middle of the algorithm. That means with the volume adjust method recommended by Asa Medical Center, choose valve size based on calcification score, or the circle method recommended by Edwards Company. These two methods are commonly used for balloon expandable valve. And in Europe, they use a Casper method and the Lira method to measure supraannular and annular sizing to choose the final size of the THV. And this was applied to the self-expanding valve. And our method can apply to both balloon expandable and self-expanding. We are very happy that international experts can appreciate this. So last but not least, we have to notice that in Notion 2 trial, bicuspid TAVR has a worse outcome comparing to the tricuspid. So in the future, we should think more when we do TAVR in this kind of patient. such as the anatomy of the aorta, we should take into consideration. In those with coarctation or aortic aneurysm, we should consider surgery. So in this kind of a complex patient, a heart team decision is really important. So finally, I would like to conclude that bicuspid anatomy are usually younger with longer life expectancy. So we should think more and discuss in more detail with the family and the patient, considering the procedure and the long-term result. The presence of calcified raphe associated technical challenges have to be solved in doing cases. And a comprehensive sizing method developed by our center, I think, can identify high-risk taper configuration easily, and you can keep the procedure safe. I think this method can be applied to both BEV and SEV. I hope that you can use it, at least try it, and then you can get a better result. I thank you for your attention.
I think that we should look at SEV test tool. It's very important to let people know some idea that the previous one. This one, two string wire.
You mean this one?
Yeah.
Oh, okay.
I think that it sometimes happens without predilation. Nose cone cannot pull it out, so that it's very important.
Sometimes the aortic anatomy was big, and if you don't predilate the valve, it is difficult for valve crossing. So for bicuspid, you should do that.
But because the nose cone cannot withdraw, so that recross, and it happens sometimes with the nose cone.
Yeah. Yeah. Any other comment? Yes.
Clinically, we use all the methods to measure for the sizing, for bicuspid sizing, for the Casper, for the Lyra, for the circular Hangzhou method, West method. Usually there's a disagreement between methods. So what's your recommendation? It seems that there's no head-to-head comparison between this kind of bicuspid sizing method for the clinical outcomes. So what's your recommendation if we have such kind of disagreement between sizing methods? Will you recommend Wei's method for the default setting?
To us, yes. To some of the experts in Asia, yes. And for most of the Chinese implanter, they do appreciate Wei's method. For many times, they send cases to us and ask how to size. We teach them, and they use our method and get a very satisfactory result. So we are willing or intend to do a registry. That means you tell us, if you submit a case, you tell us you use Wei's method or not. Finally. Then we can divide into two groups, the Wei's method group and the non-Wei's method group. And then we compare the result and the long-term result. Hope you can join.
Yes, because every time I ask Zhejiang for how to selection balloon, because Hangzhou solution is the first solution to solve the problem. In the original version is from 16, 18, 20, 22, 24, and you never know which one is the best one. So that Dr. Liu did not solve the problem. They did not know which one is best.
I think they are all approximation, and we give you an exact number. You can size the device based on the number, no matter balloon expandable or self-expanding.
In my experience, usually, if we are going to choose the balloon expandable valve, so it will be multiple debates between sizing. But sometimes just if you are going to use the self-expandable valve, sometimes there is a very unique, very same size for the self-expandable valve. So that's
self-expanding valve is more forgiving because you have a 3 millimeter range to adjust, but balloon expandable one is not. So usually if you have a borderline case, you need to balloon size, and to decide you should choose a smaller one and upsize or choose a bigger one downsize. Our experience is that if you can make the final valve at the valvular level circular with low pressure gradient, then I will choose a smaller one to make it bigger instead of choose a larger one downsize.
According to the sizing, the waist method, do you have the experience that you after the pre-diet, you change your decision about the valve, the pressure volume?
We do have some cases, but not many, because as I said, one key issue to be solved by pre-dilatation is the calcium chunk pushable or not pushable. We do have 1 or 2 cases. We do pre-dilatation and we cannot move the calcium at all. So in that case, we should be more conservative to choose a smaller one. But if the leaflet can be pushed outward, then you can properly size, and maybe you can do post-dilatation cautiously.
I think that from this case is 34 cases. And because waste method is
26, so we choose 29.
29. And after implantation, you can see there's still some constrict area in the annulus level. So when you use the 34, maybe it should be downward displacement. And at the leaflet level, the leaflet cannot open. So it's quite a huge, there's a pinwheel effect over there. So the long-term effect of such valve is not good. So it's sometimes why the bicuspid aortic valve is not as long as possible when compared to the tricuspid aortic valve.
I have to, in all this, I asked Dr. Ellen Kupier, which kind of case you won't do it with TAVR. He told me that the one you cannot open up by balloon, you should not do it. You should send the patient for surgery. Thank you. Okay, the next talk will be delivered by Dr. Yung-Tsai. Mitral valve, please.
Thank you that you here to hear our experience, and we will share some experience from the mitral valve. We begin this procedure 12 years ago from transapical one. You can see as still an incision and the blood is quite large. Then we learn about a case with transeptory because the patient received the door procedure, so that there is no route. We must puncture the septum and do the procedure. So that it's quite different when you use the transeptor. The trajectory is facing up, so that the trajectory is not good. However, for you use the transapical, it's quite simple. After you make a pulse string, so that the device in, balloon out, and the device out, close the window. So it's the time frame is a little bit different because for transeptal one, you take time to make sure you got a very good position, and you must transport the valve into the left ventricle. However, when you use the transapical one, it's everything got very quickly, and the most problem is the pain, and you make stitch on the heart. However, we do not notice the VT
or other things, such as STS say the transapical is not good. So in our patient from 2014 to 2025, 139 patients received the mitral valve valve, and the transapical patient is 86, transeptal is 53. The average is hospital. The average is follow up is not hospital days is follow up days is 1,400 days, and for transeptal because we just do it in this 3 years, so it's mean hospital the mean follow up days 400, and the late mortality for the transapical is 15, and for the transeptal is 33.8. However, we did not find two methods with any difference. So the p-value is around 0.515, and you can see that the initial the transapical got some patient drop because the patient received the ECMO, and we do the TAVR because family asked for procedure. However, the result is not quite good because of the acute pulmonary edema, the lung problem, and the liver problem. So that we no longer do patient under ECMO support because the outcome is quite bad. Even the heart become improved. However, the general condition cannot improve. So that we will pursue the patient to do surgery as early as possible. Just on Friday, we do the emergent mitral valve because the patient got a very rapid goes down, so that we do the emergent mitral valve. So during this period, we try to do the mitral valve ring, and we have a bench test doing the mitral valve so that we know that which kind of rim we can become the round shape, so that for this Edward CE class rim, that they have some leakage oversight, so that it's buried. And we also use the 3D printing to have a very good puncture site, and know which one can puncture and the correct trajectory. And for the new processes is how to do that. And the midterm result of mitral valve, the hospital days is around 14, and for transeptal is 88. So I think that's even the midterm or long term or the hospital days is good for people, and the mean hospital day is around 1 week, so that the transeptal one can give us a very acceptable result. And also we have the open procedure prevent the neo-lateral VOT obstruction, so that we push the limit, and more people satisfied about the mitral valve procedure. So we saw the electro surgery for this kind of patient, and we do the bench test and know how to do that. And this is the one we talk recently. The patient had received the mitral valve ring, and we do the open procedure. The neo-LVOT is 190. Actually, it should not be LVOT obstruction. However, this patient has had a very quite long anterior lesion, is almost 3 centimeters. So after procedure, during hypercontractile condition, the anterior lesion will go to the septum. It's called the SAM, and the patient have a low blood pressure, so that we send the patient to convert to the open surgery. Unfortunately, the patient got well after surgery. And we have several communication. This is a communication from the transapical ear, and that's because the apical, the muscle wall is quite thin, so we close the apical. However, as you can see, the apical pseudoannulum, so we need to implant a cord, and the patient survive for at least 5 years. So this is a transapical occluder. It's quite simple to do that, and the patient got recovered. You can see here no longer a leakage over the apical. And sometimes we need a second valve because to atrial implantation. So that you can see here a supravalvular leakage in the valve ring. So we need a second valve to solve the problem. So that I think everyone patient should have a monthly slide CT because sometimes we will find the LA thrombus. Just in our emergent one, there's a huge LA thrombus because of acute mitral stenosis in the bovine valve. So it's quite dangerous. Also, you need the TE monitor to direct the guide wire direction. So like common for mitral valve is rapid involving procedure in Taiwan, in Asia. As in United States, the mitral valve is go rapidly in these 2 years and still have some risk. Meticulous preoperative cleaning, especially for LVOT area, and effective teamwork because you need to familiar about the procedure. And specialized post-operative care is very important. We almost all patients receive the anticoagulation, and if even after 1 year, we still keep a very low dose operate because the patient got easier thrombosis and the mitral flow is relatively slower than the aortic valve. So that's keep INR 1.2 or 1.3 and keep the pressure gradient low. If you found the post-procedure pressure gradient going up, maybe after 1 year or 2 years, you can still rescue this valve with higher anticoagulation, the anticoagulation level such as 1.5 to 2.0. And the crucial strategy to maintain the risk and over the LV obstruction, you need the open procedure. Sometimes, most of the time, you can do the tip to base. However, in some patients, you need to do the base to tip. And the midterm outcome, I think that the mitral valve just as same as the reduced surgery. So that's the profession in was now have a prepare manuscript, and we found that in the 5 years that's the survival, mortality, morbidity, and the mass is just about the same between the reduced surgery and the transeptal mitral valve. It's our experience. Thank you.
Well, any comment?
Yes. About the case of you have done the LAPUN but still got the LVOT. What is your suggestion about the future similar case?
I think this is why if you got a very long anterior levator, I think there's one paper or two paper talk about the risk of the same after LAPUN. So that at that moment you should do the betterment. The betterment is a puncture base of the anterior levator and insert while use the balloon break the valve and doing the mitral valve. And Japan suggests base to tip is better than tip to base because you can go precisely. However, I think that for this kind of patient should receive the betterment procedure because everything was pushed to the posterior wall, but not to the anterior, and become two separate anterior levator will have the same effect.
Yeah, for some extreme cases, I think we should also consider septal ablation or myotomy or myectomy in combination with the LAPUN procedure.
For surgeries, the first times we will be the anterior, we will excise or sometimes we will transfer. So the LAPUN procedure is focused on the laceration, the anterior, but sometimes for usually our surgeons have been the precision has been transferred, not in the anterior side.
It's just a simple word to use the LAPUN. However, for bioprosthesis, it had 3 leaflets. So that's especially for bovine valve.
when usually there's a two leg facing the septum and one leg in the middle of the posterior wall. So when the valve implant, this part will become obstructed because this time I did not put in the image. And there's in the LVDOT there is a tube over there. So we cut and it's not really an anterior rivet. So there's a rivet is located anterior, so that we lacerate that rivet. So today our case is just like this kind of case.
That means we will try our best with multiple cuts to, annihilation all the leaflet facing the LVOT. Instead of just make a cut, we will just make it disappear. No more question. We move to the next talk. Dr. Chae is a surgeon. He's also an implanter, proctor-free implanter in our team. He will discuss about the aortic valve valve.
I'm Chia-Ju from振興General Hospital. My topic is aortic valve valve. The use of the bioprocessing valve was increased because of it can lifelong anticoagulant can be avoided. And there are many reasons caused the bioprocessing valve failure. And maybe the leaflet calcification, leaflet failed thrombosis, i.e. or penis formation. And here is the current guideline. HA and ES guidelines suggest that transcatheter valve involved for high operation risk patient. And there are many research showed that transcatheter valve involved had good short-term results, including low mortality, low blood transfusion during operation, lower pacemaker implantation, and low hospital longs of stay. But other research showed that the advantage disappears between 30 days to 1 year, and the reverse in favor of the redo saver 1 year after the intervention. And besides, the size of the original failed valve may influence the long-term mortality, and the severe PPM may influence the need for the reintervention after aortic valve valve. And the Pham Nhat 2 trial showed that patient outcome was associated with severe PPM. So the current result shows the short-term outcome. aortic valve valve was better than redo saver, but the long-term outcome may be favor redo saver, and this may be related to the PPM. So there are two important issues when we do the aortic valve valve. One is to keep the better hemodynamics and avoid the severe PPM and keep low pressure gradient. And the other issue is to avoid coronary artery obstruction. So, and the current research showed that in small surgical aortic valve prosthetic failed, self-expandable valve was associated with improved better hemodynamics. And the true internal diameter was associated with post-aortic valve pressure gradient. Besides, the self-expandable valve pressure gradient was associated with implantation depth. And after the BVF, and the hemodynamic status and area was improved, and BVF before or after the TAVI has both have some advantage and disadvantage. And here is the coronary obstruction risk evaluation. If this is a supracoronary risk plan, small VTC and small VTSTJ, we may need some leaflet modification. So here is the main concern during the aortic valve valve. If this is a small size surgical valve, is self-expansive valve has better, or may be better. and the implantation depth may be 0 to 5 millimeters. And BVF can improve the hemodynamics. If there is a risk of coronary artery obstruction, leaflet modification like basilica or unicorn, or maybe the Chung-Yi stenting may be needed. And here is the outcome in our hospital. We did total 87 cases of LT valve valve since 2040 to 2025. Here is the data from 2080 to 2085. There are total 63 cases, and unicorn was performed in 2 cases, and basilica was performed in 1 case. Most of the case was transfemoral, and most of the case was used self-expansible valve. There are one iliac rupture and 5 ppm pacemaker implantations, and 2 cases have the valve dislodgement, and 1 case caused mortality. There are total 2 case mortality in 6 months, and no stroke happened. There was no stroke case. And here is the pressure gradient. About 80% cases, the pressure gradient was less than 15. And we start to measure the pressure gradient during operation since last year. And all patient was less than 10 millimeter mercury. And we did total 31 BVF, and the result was similar between the BVF and the non-BVF. And if the saver size was 19, and the pressure gradient was 80%, the case was over 15. Mean pressure gradient was over 50 to 20. So most case in our hospital can do the LT valve valve, but we will choose some patients like low surgical risk and the young patient. Maybe you will need not more than 1 LT valve valve, or the patient maybe concomitant disease and or severe paravalvular leakage need surgical intervention. Then to avoid severe PPM, we will do the root enlargement at the first time saver, and the valve size at least 23 for future LT valve valve, and maybe 25 in young patient. Maybe you will need 2 times LT valve valve. Then we will do the root enlargement like the Wei-Hsian Yin, the Bo-Yang root enlargement, and the coronary high. If the patient has a CAD problem, we will do the CHGH with the saver. And if the patient need to do the root procedure, we'll try to make the coronary implantation much higher, or do the Cabral procedure, let the coronary high much higher to avoid coronary artery obstruction. Thank you.
Okay, any comments? Yes.
Thank you, Dr. Tsai. In your data, you just show that we have some patients with pacemaker after LT valve in valve. Usually, since it's a valve in valve procedures, and maybe the risk for the conduction disturbance after valve in valve procedure should be lower. So, what's your explanation for the 7.9% pacemaker rate after LT valve in valve? Thank you.
Patient, I think the older patient has more weakness of the conduction system. So when we do the LT valve in valve, the frame will compression the conduction system, cause the conduction problem.
I think 2 issues. The first is that actually, if you do a balloon fracture, that may oversize. And oversizing is one of the main mechanisms that causing conduction disturbance. The second one is that actually the surgical valve is slippery inside because of the pannus formation, etc. So after you implant the valve, initially in early days, sometimes you will just deep dive, and that may cause conduction problem. So that's why I think.
And as a surgeon, from your perspective, so what's your lower age limitation for the bioprosthesis valve for the first valve? I mean, how young you will put a bioprosthesis valve instead of a mechanical valve as a surgeon?
I answer these questions in the position of the societies. We have the discussions in the expert in our society, and we will be that the average we will be suggest that 75 that we will refer to the refer definitely will be TAVI, but below that we will discussion in the heart team. We will suggest that. And may I ask a question? So that you show that the cabo shunt, the last slide. What were the root procedures, high implantations? It means the bento procedures before?
Bento procedure, yes. Root procedure, maybe David or maybe bento. But
Okay.
for many cases, now we do the Capro procedure.
Okay, so if this is one, well, which type of the TAVI valve you will select?
You mean later?
Later, if you valve valve,
Self-expanding.
Yeah.
self-expandable.
Because sometimes, I mean, not all the cases, you will turn out to be arterial regurgitation. So self-expanding have multiple anchoring site. So it will be easier to do without migration.
Do one or two cases. Here we'll have
Constraint zone.
Yeah. So now
We'll just hold the upper crown. Makes things easy.
Professor Shi, I mean that for the young patients, like 40, 50 years old, we for the guideline recommend to put a mechanical valve for the lifelong Coumadin, but there's no possibility for the future valve for the mechanical valve. Since that here is the TAVI era, so I mean, what's your lower limitation to put a bioprosthesis valve, like a 50, 55, 60? You will put a bioprosthesis valve instead of mechanical valve.
Okay. After the SDMs, if the patients the young patients, we will expect how many times lifetime the patient have to, because we will average 10 to 15 years will be one times for the TAVI next times. So if we choose the tissue valve, we will be the enlargement. So that's why the wide incision for young in our society, we will be emphasize that if the patient first time choose the SAVA with the tissue valve and how the longevity is left. So how many times it's necessary for him to receive the TAVI procedure?
If you ask me, I just discussed this with Professor Wei yesterday. I seen the data from the surgical result. The patient with valvular disease operated earlier in age will lose life about 5 to 8 years. That means the patient, in average, cannot live longer than normal population. So in that case, if the longevity is 75, then you minus 20 years. For a patient with suitable anatomy, then I will do TAVR for the first time and then redo TAVR. You will get 20 years.
I agree. So I just mean that if the patient older than 75, and the surgeon will be argue about the patient had to be discussed to receive the.
We put a redo operation if he's a 50 years old patient, and the first valve use 10 years, and we do maybe 1 or 2 times TAVR, and then we do a redo operation for maybe he was 70 years old or 60 years old, and after the redo saver, and I think the valve can use for lifelong after the prosthetic valve and TAVR 就他如果再把从
Let's do the math. We do the first saver in age 35, second redo saver 45, and first valve in valve 55, and 2, and the second valve in valve 65. So the patient can last for the age 75.
Yep.
So it means that by the calculation, we can do bioprocesses for people age 35.
I think you should consider the patient preference and also the anatomy. If the anatomy is not suitable for transcatheter approach, then you should persuade the patient to undergo surgery the first time. And then things may becomes easier because nowadays we have a better transcatheter heart valve, and we have better leaflet modification, and we have surplus. Surplus means you make a small hole on the aorta and excise all the valve tissue, then put the second transcatheter heart valve. And you can do that 2 times. Then why not do TAVR earlier? Okay, thank you. Let's move on. Dr. Lin Huan-Chiu from our hospital will present conduction disturbance after TAVR.
So good afternoon, distinguished moderator and our audience. I'm Huan-Chiu Ling from Zhenxing General Hospital. Today, my topic will be about the predictor of permanent pacemaker requirement in aortic stenosis patient undergoing self-expanding valve TAVR using the cast overlap technique. I have nothing to disclose. As the indication of TAVR has expanded to younger and lower risk population, lifetime management has become increasingly important. Therefore, in pursuit of better clinical outcome, it is crucial to recognize and anticipate potential TAVR-related complications. We all well know there are big 5 peri-procedure complications that significantly impact long-term clinical outcome after the TAVR procedure. Among the so-called big 5 complications, conduction disturbance are one of a concern, such as the new onset left bundle branch block or intermittent high degree atrioventricular block pose a potential threat for the patient and may explain sudden cardiac death during the follow-up. So new onset LVBB or permanent pacemaker implantation after TAVR are associated with an increased risk of all-cause mortality and heart failure hospitalization at 1-year follow-up during the meta-analysis data. And also the peri-procedure new onset LVBB also increased the risk of cardiac death and PPI within the year following the procedure. Several prior meta-analysis studies have confirmed that even with the newer generation device, that the Evolut platform consistently demonstrates a higher risk of permanent pacemaker implantation compared to the Sapien platform. So because of the proximity of the atrioventricular conduction system to the aortic root, high degree AV block and also the new onset or BBB are the most commonly reported conduction abnormality after the TAVR procedure. So in addition to the thorough CT analysis to understand each patient anatomy, how to optimize implantation technique to precise control our implantation depth of the valve is critical, especially for the self-expanding valve. In the Evolut platform, like the Evolut platform, the self-expanding valve. So Today, there's the new technique called the cast overlap technique, which facilitates higher implantation and consequently reduce the risk of conduction disturbance. So in this simulation, we can see when we push the wire or even we push the delivery caster, the whole system the wire will bias to the larger curvature of our ascending aorta. So the vice versa, when we pull the wire or we pull back the delivery caster, all the things will move to the lesser curvature. So this is how we adjust the implantation depth during the deployment of the self-expanding valve. So like in this case, when we do the cast overlap technique, the valve was deployed at a higher position from the maybe 1/3 of the diagnostic pigtail caster, which is at the nadir of the NCC, using the fluoroscopy cast overlap view. The cast overlap view is achieved by adjusting the fluoroscopy angle that we can angle that the RCC and the LCC will overlap, and NCC will be isolation and center between both RCC and LCC. So this is typically a IO caudal position. So after releasing the valve, it descends into the left ventricle, and usually we would like to stop at around the 1 to 6 millimeter below the annular virtual ring at the NCC side. Then at the point of no return, the fluoroscopy will rotate to the LAO view that remove all the parallax. So we can align the fluoroscopy angle correctly to avoid the visual distortion. So that making the aortic annulus appear as a perfect circle. So the delivery caster can free from angle displacement to ensure that the inflow is neither supraannular or the depth is not deeper than the 6 millimeter. So once the final position is confirmed, the implanter may retract the wire, then the nose cone can go back to the neutral position. Then we will slowly release the valve from the delivery caster and by rotating the paddle. So the final aortogram will be performed, the valve is released, and it seems that this valve will stand and function pretty well. So in our center, we would like to compare the outcome of the conventional method and also compare with the cast overlap technique. And besides, we'd like to identify is there any predictive risk factor for conduction disturbance, especially in patients using the cast overlap technique. So between 2019 and 2022, this is a retrospective study and only single center. So our case number was a little bit small. The conventional group is 50 patients, and there are 47 patients in cast overlap group. So how do we measure the implantation depths? We will measure the implantation depths that in the LAO and LAO view and release the parallax. So the implantation depths before and after will all be measured accordingly. So this is our main result between the cast overlap technique and conventional method. The patient in cast overlap group demonstrates significantly lower rate of new onset LVBB in both OR and 1 week after the TAVR procedure. Moreover, the permanent pacemaker implantation rate 1 week after TAVR was also significantly lower in cast overlap group, which is only 4.3% compared to the conventional group, 18%. So a proportion of patients who initially present with LVBB, as you can see, 1 week after the procedure, it have self-recovery. The percentage of self-recovery is around maybe 20 to 30% in our patient group. So all of the patients in cast overlap group have achieved higher implantation and higher implantation depths, including pre-release depths and the release depths. So the release and pre-release membranous septum length minus the implantation depth below the NCC was significantly shorter in the cast overlap group compared to the conventional group. So significantly, the deeper pre-release and release implantation depths beneath the NCC and LCC will correlate with the increased risk of conduction disturbance. So we do the multivariate analysis, and which further identify the LVOT parameter and also the membranous septum length measured by the coronal method instead of the Midas method, and also the pre-release depths below the LCC, not the NCC, as a significant predictors of the permanent pacemaker implantations. I think since the membranous septum may extend partially to the LCC, and the His bundle may pierce a membrane portion between the NCC and LCC. Sometimes this may cause, sometimes if we are much deeper in the LCC, that it will even cause the conduction disturbance and the need for the permanent pacemaker implantation. Other huge multi-center study involved more than 1,000 patients and also show that the cause overlap technique has a lower rate of new permanent pacemaker implantation and also less paravalvular regurgitation after the procedure. So in conclusion, using the cause overlap technique significantly reduce the risk of new onset LVBB and permanent pacemaker implantation after the TAVR procedure using the self-expanding valve. So refining the technique by keep the self-expanding valve implantation depth within 1 millimeter of the membranous septums and maintaining implantation depth for less than 6 millimeter over the LCC side before the final release may further optimize the cause overlap technique and minimize the risk of permanent pacemaker implantation. Thank you.
Okay, any comments? Cause overlap is focused on self-expanding because self-expanding usually is this side, the left side is turn finally, then this side will downward displace. So that's why I think the LCC side is also important. You pull the wire, you release the tension.
Yes.
Or you push the wire, it goes up a little. Both can be done. Yeah. Okay, thank you. Then let's move to the last talk by Dr. Lin Jin, our cardiology fellow, who have spent a lot of time in analyze the deep risk captured by cerebral protection device.
Good afternoon, distinguished moderator and panelists. I'm Emily Jing from Jiangxing General Hospital, and I'm going to share our experience of Sentinel experiment. So we have a conclusion of comparison of cerebral emboli debris captured during TAVR, influence of valve morphology and valve type. So let's take a closer look at the stroke timing for the post-TAVR based on the retrospective cohort study. So we can see the majority of stroke within the 30 days occur within first 3 days following TAVR. In the picture, we can see the steep rise of the curves, and almost half of the stroke occur within the first day following TAVR, and 68% of stroke occur within the 3 days following TAVR, and the majority of the stroke is ischemic stroke. So series of trial was performed since 2012. We can see the overall pre-procedure stroke rate after TAVR has remained between 2.3% and 2.8%. So due to the ischemic stroke, it's due to the debris embolization. So different types of CEP was developed, and in Taiwan we use Sentinel. So this is the protect TAVR, which is we want to know is the cerebral emboli protection is necessary for the TAVR procedure, and the outcome is the all stroke was not reduced when using CEP. However, the significant reduction of the disabling stroke. So the subgroup analysis that we can see that the SEV and the female patient has a higher stroke rate after the TAVR procedure. So we can see this one BF BHF PROTECT TAVR is the extent study of the PROTECT TAVR. It has the similar result that the routine use of the CEP did not decrease the incidence of stroke within the 72 hours. So we are curious about the valve type, if the valve type is an important issue for the stroke incidence. So 2019, there is a meta-analysis found that there is no difference in both groups. And then another author showed that the stroke rate in SEV is higher. However, the soft TAVR showed that BEV has a higher stroke rate. So we try to analyze our study in our center. So our result was published last year, and we include the patient. We use the Sentinel since April of 2022, and we try to analyze the debris since March of the 2023. So we collect the patient between the March of 2023 and December of 2023. It includes 75 patients. So we can see this. We have 39 of patients receive SEV and 36 of patients receive BEB. So all the patients we receive Sentinel deployment. We try to analyze the composition of debris, particle counts, and particle size. The particle size is based on the vessel diameter of the circle of Willis. So this is the baseline characteristics of our patient. We can see there is a significant difference in genital and coronary height. So the patient who receives BEB has more adjunctive PCI, and there is significant difference of total procedure time, fluoroscopy time, and contrast agent use also. Picture A shows the captured debris by CEP, and we have valve tissue with calcification, thrombus, degenerating valve tissue, and atheroma with calcification by pathology. So we can see there isn't any difference of component between both groups. However, we can see the patient who receives SEV has more capture of debris larger than 5 mm. So univariate and multivariate logistic regression analysis was conducted. So only valve type is significantly associated with particle larger than 5 mm, and the patient who receives SEV was high risk 16.78 times of higher risk than the patient who receives BEB to capture the particle larger than 5 mm. So we are curious about if the procedure complexity is the important issue. So we try to analyze the particle counts, particle size, and the reposition time. So this figure shows that if you have more reposition time, the more captured debris was not. So we have a small conclusion here that SEV is more likely to produce particle larger than 5 mm, and the quantity of the particle may be positive or correlated with the number of the reposition. So how about the valve morphology? So in 2020, there is a published in JACC that we found that the patient with BAV patient were associated with higher number of new lesion, total lesion volume, and the total volume per lesion via brain MRI. So this one that mentioned that the patient who receives CEP in BAV has less stroke rate. So we try to extend our study. We collect the patient since April of 2022 and to October of 2024. And then our number increased to 202. So the bicuspid aortic valve number increased to 29, and then the BEB increased to 84, the SEV increased to 118. So we analyzed the components of the debris, and there is still no significant difference between both valve morphology. However, we can see there is a trend that the more calcification was not in the patient of BAV group. So the extent study showed that the similar result that the patient who receives SEV has more medium and large size of particle count. How about the aortic valve morphology? That we can see that the patient with bicuspid aortic valve has more small size of captured debris. So how about if we have the combination of the BAV and SEV? So there is no difference of BAV and TAV, but we still can see that there is the SEV is still the important issue that we can have more medium and large size of capture debris. So how about the subgroup? We can categorize into 4 subgroups. So the small size debris we can see bicuspid is an important issue, and the medium size the SEV still more important. However, we can see the SEV with bicuspid patient has more debris count. And then the SEV is the most important issue that we have captured debris larger than 5 millimeters. So how about the reposition? Is positively correlated to the reposition time. So we have a conclusion that the debris is captured in all our TAVR patients who resist TAVR. So it's potentially increase the cerebral and microemboli risk and might to contribute to long-term cognitive declines. And then the patient with bicuspid aorta may have captured more debris smaller than 2 millimeter. The patient who receives SEV has significantly more debris larger than 5 millimeters, and it might be associated with the increased procedural complexity. So the patient who receives SEV have higher cerebral emboli burdens and might influence the cognitive decline and vascular dementia in the future. So CEP is crucial, especially in the patient with young age, and also if the patient with bicuspid with undergoing SEV is more important to have cerebral emboli protection deployment. Thank you.
Okay, any comments?
Okay, according to this data, the suggestion, the recommendation is very important. But currently, the embolic protective system is still not significantly reduced stroke. But the general aortic valve implantation population. So, is there any data that subgroup that use embolic cerebral protection system for such as bicuspid valve and self-expandable implantation? The use protect system or not, is there a significant difference?
And we can see this picture. Actually, we have the borderline of and also the significant difference of both group of BEB and SEV. So, however, in the previous hour published that we cannot see any independent factor for their debris capture.
So the only factor we found is the use of SEV. So in every SEV patient, we strongly recommend to use CEP. But we also know that actually with the current generation of TAVR devices, and the incidence of stroke was really low, about 2% only. But in our Taiwanese registration by the National Insurance database, the risk rate was really high. They told me that it was 5 to 7%. So if that's the case, then we should deep dive the data, identify which population will be benefits from the use of CEP. Instead of the data only show that you should not routinely use it, but we cannot say which kind of patient won't get any benefit from using CEP. So at least up to now, in our center, we still use it routinely because we know that in all patients, we can capture something. If we didn't use the CEP, the debris would have ended up in the brain somewhere. We don't know the long-term result. Although some data showing that the neurocognitive function improved after TAVR, that might be something to do with the valve itself. And the valve have been solved, the problem have been solved, the neurocognitive function improve, but the price is that maybe you can get a long-term neurocognitive dysfunction. This might be important for younger patients. So for younger patients, intend to use self-expanding valve, we still strongly recommend to use CEP.
Another ask the recommendation, because the stroke, the TAVR stroke occur during the procedure is only about less than 50%. More than 50% is after the procedure. For this stroke population, do you have recommendation how to reduce the incidence?
The data showing that there is a meta-analysis of the both large trials in the presented in the Euro PCR this year, just last month, showing that in per protocol analysis, if the patient if the CEP can successfully deployed at both carotid arteries, there is still a significant difference in the instance of disabling stroke. If you discuss that with the family and the patient, they are worrying about the disabling stroke. They would rather to die if they got a stroke. So every patient or family, when we discuss this issue with them, they agree to use cerebral protection.
Professor Shi just mentioned that the time of the stroke after procedure.
Yeah,
so
as shown in the slide.
Yes, a lot of stroke time is after couple hours, even days after the procedure, which means that this kind of stroke cannot be protected by the Sentinel device because we retrieve the system immediate after the procedure, so we cannot prevent the stroke event 2 days after TAVI.
But unless that's a major stroke, you cannot find it immediately. In many patients, they are under general anesthesia. If wake him up and then remove the tube, then you find something. That might happen.
So my question is that, is it since it's transradial, is it worse to retain the cerebral protection maybe 2 days or 3 days after TAVI, then we remove the Sentinel?
Yeah, that's why it's a hot topic to be discussed. If the patient has some disease in the vascular system, that may worsen the clinical scenario or the result. Some, you know, the two study. The first one, the protected TAVR study, they exclude those have unfavorable anatomies, and the successful deployment was achieved in 92 or 90 something % of cases. But in the BHF study, the successful development only achieved in 81%. But per protocol means that if the device can be successfully deployed, it will work. At least it can reduce the disabling stroke. That's the key message we got from these two studies. Okay, thank you everybody for your participation in this session. Thank you.
Good afternoon, everyone. I'm Dr. Zhang from the NCKU Hospital. And today I will share a case of a rare complication of the TAVI valve late migration. This is a 72-year-old woman had underlying severe AS, CAD, and ESRD, AF, and DN hypertension. Her predicted operating mortality risk of the isolated AVR based on the STS score was 10.8%. Her cardiac echo revealed LV dilatation and severe degenerative AS with an area of 1.0 square centimeter and mean pressure gradient was 41 mmHg. LVEF was 50%. The LT annulus area was 423 square millimeter. The LVOT was 402 square millimeter. There was no calcification around the annulus and the LVOT. According to the sizing scale, after hearting discussion, the patient underwent TAVR valve implantation with 23 millimeter sapien 3 valve. About the LCA and RCA height were 12 millimeter and 40 millimeter. The diameter of the sinus vasa valve was 29.8 millimeter. About the morphology show on CT show a tricuspid AS with a symmetric distribution of calcification. This is the simulation of a 23 sample valve implantation at 8:2 ratio of the valve in the L to LV. So 23 sapien 3 valve. So the transfemoral approach was implanted at 8:2 ratio. With the post-dilatation, with overfilling 2 milliliter. And immediate cardiac echo showed mild paravalve leak. No AB block was noted during the procedure. However, complete AB block developed in the ICU on post-operative day 1. So permanent pacemaker implantation for bradycardia. This is the post 1 month cardiac echo show a moderate paravalve leak between the 0 and 3 o'clock, around the right and left commissure. On the transesophagus echography post 7 months later, severe paravalve leak was found at a NCC site. So we do a catheter and the echography revealed. Wait. Sorry. Oh, okay. Echography reveal the left is the initial echography, and the right is this time. The echography show a LV OT shoulders at the NCC site. So we do a CTA was arranged. So we can see here is the LVOT shoulder region was located around the aortic mitral curtain. This is a sagittal view. This is the shoulder region around below the LT-VAR annulus. So we can see the longest view of the CTA reveal the shoulder region with the L2 to LV shunting. And the significant valve downward migration into the LVOT and the tilting was noted. And after hearting discussion, she underwent surgical experimentation and the LT-VAR replacement. And as a human figure, the left side of the picture was the cranial side. The this cross-crown was crowned at the ascending aorta. So after aortotomy, inspection revealed a ventricular migration of the sapien valve to the point where the external curtain was located below the level of the annulus, around the lung and left commissure. A 4 cm alto mitral curtain pseudoaneurysm was noted. Then the sapien valve was explanted. The M means the anterior lift of the mitral lifter. This is left and the lung. We do a wide incision at the lung and lung combination to repair the pseudoaneurysm. And the picture shows the root reconstruction and the root enlargement with a bovine pericardium patch. Then AVR was done with a 25 mm St-Ju proclaim valve. This is the intraoperative T. It shows no parabolic after AVR, and the pseudoaneurysm was removed. Then patient was discharged 11 days later. About the late downward migrated TAVR valve. The potential in etiology included undersize of the valve or the major error of the size or implantation death, or in some case report, low degree calcification or asymmetric distribution calcification was talked about. And the effect of the LT reconstruction force on the transcatheter heart valve will put the valve into the LVOT. However, we had no clear answer in this case. How to manage the migration and the pseudoaneurysm? The surgery is always an option if acceptable risk. Embolization is considered for closure of pseudoaneurysm. However, it might be failed due to parabolic through the frame cell. Conservative treatment is another option. About how to prevent migration and aneurysm formation. I think undersizing the valve might be the potential reason of the migration. Her annulus area is 423 square millimeter. The cut point between the 23 and the 26 sapien valve is 430. So important size, balloon size might be a solution. If significant leak during ballooning, we could choose the 26 millimeter sapien valve with the underfilling. Even if parabolic development after implantation, we should cross follow up the valve states by the cardiac echo or the new murmur. Early intervention can prevent the LVOT pseudoaneurysm if progressive parabolic. Thanks for the attention.
Can we show the sizing of the valve? You mean the diameter area divide?
Yeah.
Which face? I mean,
face. 20.
Might not be a profit. It's not the largest annulus. Might not be the largest.
This the size, the largest area in the. No.
So, okay, you're so sure.
Oh.
So you should do sizing by yourself.
Okay.
I doubt it's undersized. The other thing is that can you show the classification? No, longitudinal.
Longitudinal. Oh.
Previous one.
You did not cover all the calcium on the leaflet. After deployment, the recoil of the leaflet will push the device down. So you should put it higher, even flare. And can you see the angel implantation? Yeah, this one. As you can see, the tip of the leaflet is just right there. If you want to make sure it won't displace, you should flare often. But it carries a risk. I don't know. That might be risky.
So, what is the location of the Yu-Chuan during the operation?
During operation, should be no shoulder aneurysm.
Yes, the Yu-Chuan is below the annulus at the LVOT, aortic mitral curtain.
During the operation.
Yeah.
During the operation.
During operation. Surgical.
No. I mean during the implantation.
Implantation, no.
Initially, it should be fine.
Yeah.
And after displacement, the LVOT size, the other one issue is LVOT size.
Small.
Smaller than the annular size.
Yeah.
Am I right? So how about the configuration of the interventricular septum?
Septum, and I'm not put a slide.
Are there septal bulge or hypertrophy? I mean, if this is the shadow of the septum, when it was pushed downward, might injure the septum or the membrane septum.
Sorry?
In the operation, the surgical operation.
You mean surgical? Or location? Is at the NCC side, yeah.
But how deep is the laceration?
It deep to the for the size in base is 4 centimeter.
4 centi?
But dips,
No,
I'm not dips.
Yeah.
Only CT can CT.
Yeah, if you see this, I wonder it's just looking the mechanism of the vascular.
But luckily, because that side is Bo-Yang the first incision.
Yeah.
Side.
Yes.
So we can do Bo-Yang too.
And poor larger bioprocess. Yeah.
Good afternoon, ladies and gentlemen. My name is Yu-Chuan. I'm from Taichung Veterans General Hospital from Taiwan. So today is my great honor to present a case in Taipei Valve 2025. Today my topic is when the valve dives, a dual snare rescue of a migration evolute. So I have nothing to disclose. So today our patient is a 99-year-old male and with symptoms of heart failure. Actually, the patient was pretty active before the symptoms occurred. He was a badminton player. And because of heart failure symptoms, echocardiography found severe aortic regurgitation as well as moderate aortic stenosis. So the patient also have other comorbidities such as hypertension, hyperlipidemia, as well as a history of head injury a few years ago. The coronary artery was patent at the moment. And here is the first surface ECG. As you could appreciate on this surface ECG, there was no heart block and the chest X-ray showed no obvious congestion at this moment. So I have to say this is not a perfect case for a TAVR procedure in a few years ago, but in the old day, we don't have a further dedicated device such as a Jena valve or J valve. So after hearting discussion, we decided to try a TAVR procedure for this patient. So actually, there is no much calcification, only some tip calcification over non-coronary cups in this patient, but there are severe aortic regurgitation over the TTE. So because of advanced age, 99 years old, and with a high STS score, after hearting and family discussion, we decided to perform TAVR procedure for the patient. And for this patient, actually there was no much coronary risk, and the calcification was located around non-coronary cusp. So actually the valve was opening quite well. So we decided to go with transfemoral approach with a 29 millimeter evolute R, and the oversizing percentage in this patient was around 50%. So initially, when we try to cross a valve, as we could see on this angiogram, we could easily cross a valve with a pigtail. So it definitely is a typical aortic regurgitation case. So after checking the valve could pass through the aortic valve easily without any struggle. So initially, when we thought everything was quite stable, we tried to use a control pacing because there was no much calcification to anchor the valve. So after a 120 control pacing, we could slowly deploy the valve. And it seems to be quite okay initially. The depth was fine, although it seems a little bit deeper than the daily practice nowadays. But at the moment, we think it might be okay because there is still some limited calcification over non-coronary cusp. Maybe the valve could be anchored over there. So we release the valve at the moment. However, when we are retrieving the system, the valve started to dive gradually. And here is the final aortogram. I have to say it's quite horrible and scary, and because of lack of a calcification, so definitely it's a real challenge. The valve might dive during the TAVR procedure in this kind of aortic regurgitation patient. So what to do at this moment? Actually, we have a brave attempt, try to snare up the migration valve, but actually we are quite scared because maybe if we snare too much, the valve might pop out. So we make a wrong decision at the moment. We decided to close the procedure in that time. So not to mention the follow-up TTE showed a very deep heart valve and also a nearly severe valvular leak. So it's kind of a tragedy at the moment. And also the anterior mitral leaflet, the motion was also limited because of the deep dive heart valve. So because of the intolerant symptoms, we decided to arrange another procedure 3 weeks later. We decided to proceed another build-up procedure. So this time we are well prepared, and we have a lot of a discussion in our heart team, and we decided to snare it again and with a build-out valve-involved procedure if necessary. So first we have a bilateral femoral puncture, and we advance a JR guiding catheter so we could point to one stem post easily with a gooseneck snare. So first, one post was snared, and then second, we advanced another snare from right radial artery because we try to keep a safe line pigtail from the right femoral artery. Once the valve pop out totally, and we could insert another valve-involved procedure immediately. So it's just in case. So we have one snare from right radial artery, another snare from left femoral artery. So the pigtail was placed in LV just for in case. So after snaring, we could start to pull the valve, but at this moment, we should go as slow as possible. And real-time TEE guidance is also suggested from other experts. So we try to move like a hands and knee, it's like a crawling. So one operator pull a little bit and another operator pull a little bit. But the key is that we have to see what's the depth real time on the TEE. So fortunately, the valve did not pop out, and it turned out to be pulled up a little bit. So this is the initial depth as we could appreciate on this TEE guidance. And after a small pull, the valve comes up a little bit. And fortunately, we could put the valve in a better location. And there was only, I would say, mild PVL at the moment. So here is the final assessment. And we revealed probably acceptable depth and only a mild PVL on the real-time TEE. So actually, the patient is now 104 years old, and he still come back to our outpatient department. And further serial follow-up during the past 4 years, the TTE also showed nice steps and also only mild valvular leak. So actually, with the agreement from the patient, he is now 104 years old, and he still played badminton well. And he also attended the World Master Games last month in the New Taipei City and Taipei City. So here is thank you. So here is a very nice study from Dr. Kim in 2019 at the European Heart Journal. It's a travel registry. They recruit a TAVR case from 26 international sites, and actually the incidence of a heart valve migration was less than 1%. And most of the case was a jump out situation. It means that the heart valve comes up to the scanning aorta. And there are some actually risk factors, including if we choose a self-expandable one, or we are using a first generation one, or even there is a case of a bicuspid aortic aorta. So there are some causes, but the most reason was due to more positioning, and some of them was due to more manipulation. So actually, there are some way to treat. So in our case, our valve dives into the left ventricle. So what we could do is try to snare and pull out a little bit. But if there is, in case of the valve totally pop out, we could perform a valve-in-valve implantation. So here are actually some tips and tricks during the snare, although we have only limited experience. So actually, most of the experts would suggest 2 snares so as to ensure the symmetric control. And we have to try to avoid leaflet capture because it might cause further leaflet damage. And gentle traction is usually necessary, followed by a real-time TEE guidance. And the last but not least, we should always prepare a second valve. Because in case of repositioning failure, we have to put another valve immediately so as to stabilize the patient's hemodynamic. And there are still some risk during the dual snare rescue, such as a leaflet capture, or there might be a total migration. Sometimes once the hemodynamic collapse happens, it might require VA ECMO or even turn to a surgical intervention. So although TAVR migration is rare in nowadays, it might still happen. Once it happens, maybe we could consider dual snare rescue in this kind of procedure, followed by a build-out valve-in-valve procedure. So today we present a case of 104-year-old male and with incidental migration to the left ventricle, but we successfully rescue with a dual snare procedure. Thank you.
You mean the oversizing is how many?
It's 15%, with 29. 15. So if it's with 34, it's probably around 35%.
So the diameter is annular diameter?
Yes, annulus perimeter.
I mean the perimeter, 80 or 70 something? 81.
81, yes. The perimeter is 81. Yes.
81 should be 34.
Yes, probably.
Yeah.
And because
the larger the annulus, if you want to put a self-expanding, more than 80, you should choose 34.
Yes. And another issue is that we thought there's still some limited classification. Maybe the valve might anchor, but actually it turned out to be that we are wrong.
Yeah. The second thing is that you should put it higher.
Yes, that's true.
Maybe 3 millimeter, because the lower half of the valve is taper in shape. Only the distal 6 millimeter can be held by the annular anatomy. So if you put more than 6, it's just dive.
Yes, it was too deep, as you mentioned, and it eventually the valve itself tried to centralize and dive in. So
why could you put it so easily?
No, it's not easy.
No. I don't know the force you use. If you can put it up easily and even can control the depth, that means the size is still a little bit under.
Under, yes.
A little bit under.
Oh, yes. So actually, initial planning was another valve-in-valve procedure, just try to fix the valvular leak. But before another valve-in-valve procedure, after heart discussion, we think that we might give it a try, that we can snare it. But there is really a risk of no matter it dives in more or it pop out. So that's why we leave a pigtail here, just in case everything goes wrong and we could go directly with another valve-in-valve procedure. Just try to save all the hemodynamic status.
Which valve will you use if you want to do a TAVR in TAVR?
Actually, we prepare another evolute in that time.
You mean we did the first one in place and you put a second,
yes,
or you put it up and put a second?
Just leave this one in place and try to put another over here, a little bit higher over here.
Strongly recommend. If you want to see a paradox, you should use a balloon expandable because the waist cannot be opened with the second self-expanding valve. We have more than 10 cases in early days. The other thing is that if you want to do that, you just put it up and leave the first valve in the ascending aorta. Otherwise, you will have 2 layers of metal in front of the coronary takeoff. That may compromise coronary access. So you want to just put it up. You are lucky, but in real world, maybe you need to put it up. The last thing I would like to suggest is when you pull, you were lucky because this strut direct to the inward. Sometimes you put it out, it just outward. That will cause dissection or perforation.
Yes, thank you for your excellent comment. We truly appreciate it, and we learn a lot from this case. So nowadays, since this case, there is no further migration case in our team.
Thank you.
Thank you.
Thank you very much.
Okay, good afternoon, Mr. Chairman and ladies and gentlemen. So I'm Dr. Ming. I'm from Vietnam. So I'm here today to present a case which we have just done a few months ago about bicuspid aortic stenosis with the horizontal aorta. So my hospital is the Hanoi Medical University Hospital, which is quite a large one in the north of Vietnam with roughly about 700 beds, and we have about 120 beds dedicated for cardiology. So our patient today is not a very old patient. He's only 72 years old gentleman, and he is an old veteran from the Vietnam War, and he came from Nghệ An City, which is about 3 kilometers range from Hanoi, and he has a history of hypertension for a few years, hyperlipidemia, and he currently on clopidogrel, rosuvastatin, bisoprolol, and lisinopril and amlodipine for his hypertension. So 2 weeks ago, he developed some dyspnea, coughing, and tiredness, and especially he has some episode of syncope, and for about 15 minutes, and then he came to the local hospital, and then we confirmed the diagnosis of this stenosis. And then after we discussed with the patient family, we confirmed the plan for the TAVR for this gentleman. So here's the ECG for this male patient. As we can see that we can appreciate there are nothing, no conduction disturbance, although we have some kind of chamber hypertrophy. And then here's some lab tests of the patient, almost normal. Especially we have some a little bit high of the NT-proBNP and also the eGFR about 45. So here's a summary of the echo for this gentleman. He has a severe aortic stenosis with mild regurgitation, and the gradient is about 97/60, and the valve area is about 54 centimeters square, and the PAP is about 33, and the LVEF is still sustainable. And then here's the echo of this gentleman, and we can see that it looks like a bicuspid valve with a very high gradient of more than 50, and then we can measure the quite high gradient and low area of this valve. And here's some measurement for this, and we can see that the annulus is about 27 with SOV about 34, and then we have the HD LVOT about 37 also, and SDD about 33, and it looks like a BAV of type 1, and with quite a lot of calcify in this valve. And coronary height is quite well in this case, with 40 in the left and about 12 in the right, which is quite favorable for the both cell expandable and the balloon expander valve. The most problem for this case is that we can appreciate that he has quite a horizontal aorta, which is about nearly 70 degree, and all we can know that with a very horizontal aorta is a very high criteria for the fail of the TAVR procedure, or we can have some complications, especially for the cell expandable valve. And we have both the femoral access for the right and the left side good for these patients. And so we try to choose Evolute FX because this is only the third case that we do the Evolute FX because we previously only have the R system, which is quite not favorable for this kind of anatomy. But we choose in this case Evolute FX at about 29 mm size, which is oversized about 6% in this patient. And this is the planning of the procedure. We did the case under the general anesthesia with the TT assisted, and we try to use an Evolute FX 29 mm with the wire of the Medtronic confida and try to aim a little bit deep. In this case, we use only 22 French sheet with the one program in the right femoral artery, and the left it's a pigtail, and then the right femoral vein for the temporal pacemaker, and we will do the pre-ballooning with a 22 mm balloon. And here's how the procedure happened. That we always do the coronary angiogram at the same time as the TAVR, and in this case, luckily we can see that there are no sign of the coronary obstruction, and in this case, as we can appreciate that it's not so difficult in we do the wiring, and here's we wire and exchange for the pigtail quite easily, and this is the gradient in the case, and this we do a 22 mm of the pre-dilatation balloon. And besides the horizontal aorta, after the descending aorta is a little bit curved, but it is not so easy to deliver the valve into the ascending aorta. And we try to do the commissural alignment inside here, and we can see that I was the first operator in this case, and it is not so easy to deliver the valve into the place, but actually at last we can put the valve into the place, and which at first we try to deploy the valve as a standard deployment, but then we need to reposition the valve twice because 2 times the valve migrate into the aorta, and then we this the third deployment times, and we try to aim a little bit deeper, and then with this time we succeeded in to deploy the valve. So this is a deployment. So one reason why we have to do this quite quick at the third time, because at this time we could see that the hemodynamic is a little bit compromised, and we just found out that this kind of gentleman he has some kind of pericardial effusion, which is we have to solve with the pigtail and the pericardiosynthesis over here. And lastly, we found out that this pericardial effusion is due to the temporal pacemaker lead. And then after we do the pericardiosynthesis, then the hemodynamic improve quite quickly. And this is some echo we did during the procedure, when you can appreciate that after the procedure, we have quite a favorable of the gradient after we deploy the valve. And this is hemodynamic after we deploy the valve, which is quite nice and favorable. And then we withdraw the pigtail in after 2 days, and then this patient was quite stable and discharged after a few days. And here's the follow-up CT we did for the patient a few weeks ago, and we can see that the valve was really well deployed without any sign of complications. And we can also appreciate from the CT that we aimed a little bit deep for this patient, but there was no conduction disturbance after we follow this patient. And we also have a very good commissural alignment for this patient due to the CT post-procedure. And so in summary, it's the TAVR with the horizontal aorta is still challenging, but we have a better feasible with advanced system like the Evolute system, and we have also some case with the pericardial effusion due to the pacemaker lead. It is the second case that I experienced as the first operator, but we can manage well with the periocardiocentesis. So thank you for your attention.
Thank you. Can we see the sizing again? Okay, the SOV is 37. Perimeter is big as the annular level. Did you do supraannular sizing?
Actually, yes, but it is in the report that I did not put inside here. But
similar or
it is similar. It's kind of tubular. It's not. So this guy we actually we can choose both 29 and 34 of the valve, which is but I think that the 29 is more suitable in terms of both the efficiency of the valve and the benefit and the reduce risk for complication, because we use about 34 may be still feasible, but we may put the patient at a higher risk for some kind of rupture or complication.
Sure. You're right. Okay. Any comment? No, thank you. And next will be when things do not go as planned. Yeah, expected and unexpected.
Good afternoon, everyone. Thanks for letting me be here. So I'm Aekapat Phoksiri. I'm actually a young interventionist from Chiang Mai, Thailand. So the topic, as you see, is like when things don't go as planned. So let's start with the case. He is 82 years old, male, with underlying disease of hypertension, chronic kidney disease, and dyslipidemia. Actually, he presented with an exertion 2 months ago, and the ECG showed that phenolrhythm poor application. The echo as shown here. So you see that there's impaired LV functions, and the LV is dilated, and there's direct can heavy calcify aortic valve and limit operating functions. But by the way, at the time we measured the patient getting just only the mean only 16 millimeter mercury. And actually we discussed the patient that we plan to do elective TAVR at the time. But by the way, the patient come to hospital earlier with heart failure, which require intubations. So we changed the plan to do urgent TAVR. As here, just in 1 hospitalizations. And actually, we done the angiogram before the procedure, and this showed that very tight stenosis of the left coronary system, as the involvement of the left main bifurcation lesion of aortic circumflex and intermediate lesions. And the spider wheel will show you how to appreciate the involvement of the bifurcation lesion. And additionally, the right coronary system also showed the chronic total occlusion with self-collateral from the RCS itself. You see that the coronary anatomy is very complex. At that time, we questioned to our team that's what is called a dyspnea in this guys. Is it severe AS, questionable, or the CAD? And what is the revascularization plan and time in these patients? And what is the consequence and potentials that can develop during or after TAVR? And the last section, should he choose to undergo the SAVR and the CABG instead? Yeah. But we discussed with the patient and her relative, and she want to do the TAVR and the PCI. And this is the planning. You will see that the perimeter from the annulus is about 74.3 millimeters, and the SOV is allowed 77 millimeter to 30 millimeters. And there's calcium channel on the non-coronary and left coronary commissure. And the sinus height of the left is pretty borderline. It's about like 12 millimeters, and the right is about 13.7. And the femoral access, actually there's some tortuosity of the femoral artery, but there's no heavy calcium or limit lumen in these patients. So the valve size that we choose is about, it will blow size over the 26 millimeters. It's about our size about 10%. And the planning is we try to do PCI first because the calculation of the respiratory system. And we try to do the time femoral of TAVR with under side number 26. And because the LV dysfunction and then very tight correlation, we discussed with the surgeon to do under the coronary bypass. And this is the exact site. You see that with on the bypass on the left subclavian and the vein on the left groin, the TAVI from the right. Yeah. Actually, we done the PCI of the trifurcation. Everything went well. And the final angiogram we showed that the trifurcation is getting better. Even the distal lesion of the circumflex LD is maybe not the best, but we don't want to load a lot of contrast and want to proceed the procedure to TAVI to the next. We inject to the RL, the cross overlap to see the plane of implantations. And we try to inject a dye to see the depth of the TAVR, which is in this angle is quite okay. But by the way, we change the angle to the L, more LAO. You will see that it's quite shallow. The device is a little bit up. But unfortunately, and we deploy this device with this depth. Yeah. And the angiogram as shown here. You see the significant severe aortic regurgitation at the time. And what next? Yeah. At the time, we decided to put another valve in with evolute number 76 also. And we put it more deeper compared with the previous one. And you will see that there's some under expansion on around the non-coricus. And we used about 24 balloon to post-dilate it. And actually the balloon is quite deep, but actually at the time the patient is still stable. And the final angiogram showed there's reduced degree of this aortic regurgitation, but there's some still seen from the injection. At that time, we decided to finish the procedure and leave the patient. The patient plan to transfer to the CCU. But by the way, 1 hour later, the patient developed the VFLS, but actually, patient is still in the hybrid operating room. So we reinsert the coronary bypass and we look at angiogram. We done the PCI. Actually, there's some flow that you see, but we still concerned that what is the issue of the patient because the patient will have VFRS, and we put imaging to see what is the cause of the VFLS. Actually, the lumen of the left main that we put stent is okay, but by the way, we saw something that looked like a thrombus in the osteo left main, and actually from the angiogram that it before earlier, we not sure that there's some coronary obstruction or not from the second valve. At the time, we're not sure what is actually caused the VFLS in the patient, so we decide to put another the chimney stent in this patient to protect the coronary obstructions, and the procedure went well. And this is the final angiogram after we put the chimney stent. But by the way, after we finished the left one, we try to engage to see how it's going on the right coronary. But by the way, honestly, we cannot engage. We change the catheter about 5 to 6 catheter. We can just partially engage on the right coronary. And you will see that some kind of thrombus on the proximal part of the RCA. But by the way, we leave it because actually it's already the chronic total occlusion before the procedure. And then we think that the explanation may be from the left side. Yeah. Here. And it's the progression that unfortunately he went out with the ECMO on the CR, the renal replacement therapy, and the LVEF is replaced, and there's a significant power leakage. And by the way, because the timing of the CPR is quite prolonged, he not awake. The neurostatus went down, and CT showed that he have severe HIE. And we lost the patient on day 10 after he get it on top with infections. So what I learned from this case, first, is the timing of the PCI that in this patient should be due before or after TAVR gonna be better idea. And the second, if the valve implantation get complication, that like the valve is pop up or turn to embolization, should be implant the second valve, or even the same tall valve, or change to the short frame valve, or we should snare it up, or we should convert to surgery. And the third one is the risk of coronary obstruction, especially when we implant the second valve. That can cause the coronary obstruction that we maybe consider to put the chimney stent before the procedure. Yeah, that's all about my part of learning. Thank you.
But how do you so sure there is coronary obstruction after TAVR? How can you so sure there were coronary obstruction after TAVR?
Because the patient has a VFLS, we're not sure that is caused, the likely cause that we think at that time is coronary obstruction or not. Yeah.
Yeah, toe-in-toe combination can make things much tough.
Yeah. You mean the first valve?
Yeah, because when the patient got the cardiac arrest, and you will think right away about the coronary obstruction. So I think that you had some kind of prediction of the coronary obstruction in advance before you proceed with the TAVR case. So in my opinion, in the first procedure, is it necessary that you can do something to protect the coronary in advance before you do like we can do the chimney technique at the first time you do the TAVR, rather than when the patient has got the cardiac arrest, and then we do it as a bailout procedure to fix the patient after the cardiac arrest. So what do you think?
Honestly, actually, at first we think that the patient is the risk of coronary obstruction is not that high because it's about 12 up. But by the way, just for the first valve, but in the second valve, we don't realize that it can cause problem, and there's a point of learning that we don't check the angiogram before we implant the second valve. Yeah.
Can we see the coronary high
from the CT?
Yeah.
You measure the length of the leaflet before you do the TAVR case?
Honestly, and the point is I didn't measure the leaflet before.
See the coronary high on the left side is
12.2. Yeah.
Yeah. So if you end up with a 0 for the first valve, then the inner skirt will be 14.
Okay. Yeah.
So that would definitely compromise the coronary flow.
Okay. Yeah. Because it's very shallow. Yeah.
So in that situation, you should put it first up to the ascending aorta, as I mentioned before. And that can leave the second valve only have one layer of a metal there. And you intentionally put the second valve deeper, maybe 6 or 4. That would be safe.
Yeah. You mean the standard, the first valve up to the ascending aorta? Okay. Yeah.
No major branch there.
Yeah. Thank you so much. Yeah.
Thank you. Will be also a coronary case.
Good afternoon, Mr. Chairman. Good afternoon, everyone. So, my name is Dr. Paulo Prada. I'm from Manila, Philippines, and I would like to share to you our cases in TAVI. Medical City, that's where I work in Manila, is a startup TAVI center. We've just started implanting valves after the pandemic, and so we'd like to share with you some of our early cases, and in particular cases with low coronary ostia. And in our center, we only have one valve platform, and that's Medtronic, and we don't have the Edwards CPN valve yet, and so we're kind of forced to work with one platform for low coronary ostia in TAVI. And our first case is an 82-year-old female with a recent ACS. The valve is really severe. It's a 62 millimeter gradient. but the patient has a concomitant coronary disease. And that time when we started working on this patient, this is the echo. Rivastavi wasn't out yet, and that time we started fixing coronaries first before implanting valves. And this patient had a very critical left main stenosis and a concomitant right coronary artery, which we fixed first before rescheduling the patient for the valve procedure. And before the valve procedure, you'll note that all the diameters are very small, very typical of a Filipina. The sinus valsalva diameters were under 30. And of particular interest for this particular patient is a very low coronary ostia at 8. And so we're forced to work with a platform very known for coronary obstruction with a very small anatomy. And these are the pre-planning scans, and you'll see that the SOV diameters are under 30, and the left coronary height is at 8. We had no problems on the right, and we all know that when coronary ostium obstruction happens, it's usually there's displacement of the leaflet over the coronary ostia. The evolute platform is very prone to that obstruction, and in this particular patient, we have low-lying coronary ostia in a supraannular valve position. And just to demonstrate the risk of coronary obstruction, and this is because of the tall valve frame, likely to move the leaflets to the coronary ostia. So when we started working on this case, the patient underwent PCIF the left main to the circ, and we fixed the ostial right coronary artery, and then we proceeded to deploy the valve using a valve coronary protection maneuver. And in this case, we just put in a wire through the left main coronary ostium and parked a stent in the mid-LAD. Deploy the valve with the guide cannulating the left coronary ostia. And then on release of the valve, it appeared to be adequate. There was still coronary flow across the coronary ostium. And we just simply pulled back the stent, and the procedure was completed. And in this particular case, we decided to implant low, and the depth was about 7.5 to 8. And the decision to do that was because if you remember the design of the evolute, there's like a slight tapering in the waist, and that would allow us more room for a very low coronary ostium at 8. And so fortunately, we didn't have any problems with that case. Let's skip that. And this is the final aortogram for that case. Now, sometimes we have problems with coronary protection, and I'd like to share to you another case. This was presented in Germany last year, and this was a 90-year-old female, and this is the TAVI workup. The coronary height was at 10. In this particular patient, we had small femoral axis, and then we had to ask our surgical friends to make us a conduit in the distal aorta to be able to advance the valve. This is the echo, severe AS. And with this particular case, the issue was when we did our coronary protection maneuver, we were able to successfully deploy the valve, but when we tried to retrieve the stent, we snagged the stent in the left coronary. We're not sure what the exact mechanism was. Maybe the stent caught the tall valve frame struts, or maybe snagged into some calcium in the coronary. But as we started to retrieve the stent became partially stripped from the balloon. And so we had no choice but to deploy it and just re-enter it through another system and try to optimize the stent. And this is the final angiogram after that maneuver. Unfortunately, we could not advance devices past the distal left main, and the patient ended up with this result. The flow was still adequate. There was no ischemia, and the gradient was good. And the patient still follow up with us today. The patient is already 93 years old. And that's the last slide. Thank you for listening.
When you do coronary protection, I will strongly recommend to use extension test.
Yes, we thought about that. In our early days, we did not use guideliner when parking stents, and we just did entrapment of the guide. But now we've seen more and more guideliners being employed in coronary protection. If I were to redo the case, I would do the park the stent on a guideliner on the guide and trap everything there, and then retrieve the stent through the guideliner. And also to bail, and I thought about this even after we completed the case, to bail out the entrapped coronary stent. I thought about cutting the stent and passing a guideliner down into the tall valve frame and into the coronary. But I thought about that after the case had been completed, and so that would be a bailout that I should have tried.
The other thing is that to put a second guiding, such as do that in the ping pong guiding way.
Yes, ping pong guiding.
About experience in using the guideliner when you use the chimney technique during the coronary protection during TAVR. You normally use the stiff guideliner system like guideliner or guidezilla, or I think it's better to do the more flexible and softer like the Guide Plus system. So what do you think about the case?
Maybe it makes sense to use softer guideliners. Like in our lab, we already have the Asahi Nipro guideliners. These are more slippery and more maneuverable guideliners that are out in the market compared to the traditional Guidezilla. And
Yeah, because of the pre-shaped angulation of the guiding, it is really tough if the space is narrow. Yeah. Thank you.
Thank you, Dr. Wei. Thank you.
So Dr. Tsai will present the last case. Also a coronary issue, but in surgical valve, failed surgical valve.
I present a case of LT valve involving high coronary obstruction patient. High risk of I'm Dr. Chia-Lu from Zhenxing General Hospital. And this is a 72-year-old male who suffered from dyspnea on exertion for months. She had already received 3 times open heart surgery since she was 22 years old. At 25 years old, she received mitral valve replacement at first, and then reoperation for mechanical valve. Then she received 3rd time surgery for a critical AS. After 3 times surgery, she had already received pacemaker implantation, and the current cardiac echo was found like bioprosthetic valve dysfunction with valvular AR and severe AS. The mean pressure gradient was about 44 millimeter of mercury. Of course, the patient refused for the 4th time surgery. And here is the T during operation. We can see that the leaflet was thickness and restriction motion. Leaflet was restriction. And here is the LT valve, is the AR. And she had received the Perimon 90 millimeter valve, and it is a flexible valve and suggests insertion with the evolute 33 millimeter or Sapin 320 millimeters. And here is the CT analysis. The sinus valsalva was small and coronary head was low, around 8 millimeter. And the VTC was about 6.1 at the RCA and 2.9 at the 6.1 at the LCA and 2.9 at the RCA. And the VTS TJ was about 1.8 at the RCA and 1.2 millimeters at the RCA. In RCA, the VTS TJ was quite small, so it's a high risk for a coronary obstruction case. So here is the heart team discussion because it is a small surgical valve, so we want to do the BVF to increase the EOA. So the RCC modification was needed. Then, then our second plan is if we fail to do the RCC modification, we will protect the RCA and implant the Evolut FX much deeper to increase the space for RCA. And here is we use the AO guiding catheter with a modified pigtail under LAO 24 and the cranial 12 to put the catheter in the RCC. Then we shift the RCC in phase view under RL 59 and the cranial 24. So we try to pass the leaflet, but this time it was failed. So we changed our catheter. So we changed our catheter, another guiding catheter, and used the in phase view, confirm the wire position with the T. So we think that the catheter direction was good, and it can avoid to penetration to the LVOT. So then we try, and we use extra cautery about 50 watts to penetration the leaflet. And we check the wire position from the T. So we check the wire position with another view, different view to check the wire. Then we do the angiogram to check the RCA. Then we used a 3 millimeter balloon and a 4.5 millimeter balloon to do the predilatation and confirm the position by the T. And then sure. Then we do the BVF, use the Unicomb procedure. So we can see here here we can see the frame of the valve was fractured. Then we deploy the Evolut 23 valve. Then we do the post-dilatation with the 20 millimeter balloon. And the echo measure the pressure gradient was about 9. Then we check the RCA again. The flow was quite well. And here is the final hemodynamic, shows no pressure gradient. So we did the RCC modification with the Unicomb procedure. We used a guiding catheter with a modified pigtail and elasto wire to penetration the leaflet with 50 watts cautery. Then use the small balloon to increase the penetration hole. Then use the BVF balloon to fracture the valve. Then the intra-leaflet implantation at a new transcatheter valve.
Okay, any question or comment?
Acceleration and the ballooning. And how about the hemodynamic status after the ballooning?
Quite not under stable condition, so we could do it. And not the severe didn't cause the hemodynamic unstable at that time.
I think the key is that you should have your stiff wire already in position and prepare the valve. Then if the hemodynamics is not stable, you deploy the valve rapidly, no matter the depth. Then the patient can have a period of time to be stabilized. And then you can try to adjust the position afterward. Any other comment? Okay, thank you all for your attendance of this meeting. Thank you.